Hi, everyone. What a beautiful day and what a wonderful program that Dr. Lilly has worked so hard on putting together for everyone. We're excited that you're all here with us today. And a lot of planning's gone into this, a lot of details, a lot of passion, and we hope you enjoy the program. So a few years ago, we did this for the first time, and it was kind of an East meets West scenario. And from the East Coast of, Jacksonville, Florida, where Dry Eye University originated, and then to the West Coast, where this program, Dry Eye Academy, has come from. It was born here. So we have members of Dry Eye University here and Dry Eye Academy here, and then some distinguished guests that are going to speak to us today too. So, first off, I want to just introduce myself just a little bit. My name is Patty Barkey. I am the CEO of Bowden Eye and Associates in Jacksonville, Florida. I was the founder of Dry Eye University, and I'm very, very, very passionate about dry eye disease, ocular surface disease, whatever you want to call it. I personally think calling it dry eye disease is a big move because I think it resonates with patients. Ocular surface disease sounds something like a cosmic concert. And I don't think the patients necessarily get that. Using the word disease instead of just dry eye gives the patient the notion that it's like ocular hypertension or diabetes or something else that requires their care and their responsibility as well. So with that, I'm currently the president of ASOA, which is the American Society of Ophthalmic Administrators. I know how many administrators are in the room? Okay, Debbie. Ooh, no. This is such a large disease and educational process that we have so much passionate work to do in front of us, passionate work that's been done, but more to be done. And for those of you out here, it is important that everyone in your practice is involved, the administrators, the billing departments, the call center people, the technicians, the physicians, ophthalmology and optometry. It is important that everybody comes together to be able to solve this problem and get care to these particular patients. So with that, I want to introduce first, we have this distinguished panel sitting up here. I don't want to introduce all of them and all their achievements quite yet. We'll do that right before they're speaking and delivering their message for today. But first, I want to, recognize who is sitting up here. And our dear Dr. Lilly sitting here today, who is she is amazing, let me tell you. And many times I've gotten called the queen of dry eye. I've been dubbed that by some people. And I want to say that we're now at the time of kind of like Games of Thrones, where we have kingdoms. So I do say that you have this kingdom, okay? You are dubbed the Queen of the West. All right. So and I think that's important because we need more passionate people that really live and breathe this to get these patients the care they need. So we also have Cheryl Jennings. Cheryl, if you can give a brief. She's going to speak to us on a patient perspective and has gained national attention herself in her market and with what she does. We have Dr. Frank Bowden. Dr. B, he and I have worked together 26 years. And I often tell people when I first went to work for him 26 years ago, he was putting MGD in his slit lamp findings. I had no idea what it was and had to ask, but that's how long he's been caring about dry eye. Dr. Sarah Darbandi, she has worked with our practice now 12 years. Yeah. And she is just awesome. She's embraced dry eye. Our entire practice embraces dry eye. We have the wonderful vendors around the room, and we want to make sure that you do spend time with them. And we thank each of them for being here today. It's It's like a giant, giant puzzle to care for these patients. And all of these pieces are the piece of a puzzle to help in this care. You know, treating the root cause of the disease is so important, and there's never just one little easy button to make this happen. So with that, I want to have Dr. Lily come up, and it's a privilege. You know, she's distinguished. She's a distinguished figure in the field of ophthalmology. For over 25 years, she's led a thriving multi-location practice in San Francisco. She demonstrates exceptional expertise in areas premium cataract surgery, complex dry eye management, diabetes, glaucoma, medical retina, autoimmune related. Wow, you're just doing everything. On top of that, you know, she's a fashion designer as well. Her involvement in the aesthetic field, influenced by her residency under Dr. Alan Scott, has expanded to encompass a wide range of aesthetic center practice, which, you know, is a natural thing. We have a lot of things in ophthalmology that naturally go together, and that's one of them. Her contributions extend beyond her practice. She's a founding partner in the Eye Surgery Center of San Francisco and has been an integral part of its success. With a commitment to advancing the field, she's been involved in pharmaceutical research, dry eye treatments, clinical research on premium IOL performance, and she's a patent holder for multiple inventions, including a dry eye device. Please join me in welcoming her to the stage up here, and a true luminary in ophthalmology. And I can't be prouder to be a part of this program with her and to look at what she's done to make this thing take off.
Hello and welcome. First off, let me thank each and every one of you. You are my esteemed guests, and it's a pleasure to have you here. Some have traveled from long distances to be here. This program is going to be a bit different than other programs. Usually when I speak, I'm speaking science. In this program, I myself, I'll talk science when I'm treating patients, but I would like to come from the heart and deliver a message today. That is the whole purpose for why I put the program together. Dry eye disease is a serious disease. It affects many people and it needs serious attention. The whole purpose of this meeting is just that. And let me do my real talk. Again, it's there is some call for action in my talk. And then, you know, when it comes to the science, we'll cover it later on. Well, with that, let me start with the first slide. Eye health starts at the surface, but I want to add to that, it also finishes at the surface. Towards that, how big is this problem? It's a growing problem because the population is growing older, so it gets worse as one ages. But then we live in the age of technology. Even our kids are in front of screens for multiple hours a day. I have 10-year-olds in my practice who are suffering from dry eyes. And that is if they're lucky enough for the parents to recognize it and bring them to us. It's a disease that is affected by other disease processes, the autoimmune diseases, rosacea, hormonal changes. I tell my patients hormonal changes happen in both genders. In women, I call it menopause. We call it menopause. In men, I call it menopause. But it happens in both genders. It needs serious attention because hormones do affect dry eyes. One of the things that I often get asked by my colleagues, you ask about hormones as an ophthalmologist? Yes, I do. And you'll see later in my talk how we need to be holistic doctors to treat any disease entity, especially dry eyes. The prevalence in the world is over 745 million. In this country, about 85 million. 86% of the population that suffers from dry eyes suffers from evaporative dry eye disease when they're lacking the oil layer on the surface of their eyes. About 1 out of each 2 patients who walk into our offices have been estimated to suffer from dry eyes. I think that's an underestimation. At least it is in my practice, but I'll give you reasons why I think that. They say about 60% of our surgical patients suffer from dry eyes. An underestimation, in my opinion. I'll tell you why later. The reason I think the reports are underestimations of the disease is because it's a silent disease. We'll get into that a little bit later. The reports, depending on which literature you look at, vary. They're all high, but they vary. One could be 84%, one could be 86%. But the one thing they all agree on is that this disease has become the most prevalent disease in the field of eye care. And the fact that it affects all ages, all occupations, and all genders. The true statistics, in my opinion, are much higher. And the reason being this: most of these estimates come from symptomatic patients and patients who are being diagnosed in doctors' offices. Most of the patients who suffer from dry eyes, as some of our patients will attest, they don't even know they have dry eyes when they're kids, when they're teenagers. So this estimation is a gross underestimation of the number of people suffering from this disease and their ages. I'm going to proceed and go to the next slide, and then I'll come back to some of the points. The spectrum of this disease is a wide one. In this mild form is merely a nuisance in your daily activities. My husband and I could be driving to home and saying, oh, my eyes are dry today. You know, we have to blink a couple of times to clear our eyes. But that's only when it's in this mild form. As it progresses, it becomes debilitating. It handicaps people. And it's a serious disease. When it goes undiagnosed and untreated, it affects them for the rest of their lives. In its advanced form, it's an actual crisis in people's lives. And unfortunately, many of these people who have that advanced form, they're young people, they're young mothers, they're technology workers. It affects them in every aspect of their livelihood. They cannot perform their work. They cannot be normal in their social activities. It gets so advanced that even when they come and find those of us who care for the disease, we come short in giving them relief, sustainable relief to go through their daily activities like a normal person. My first call to action: we need public and professional awareness of this disease. I want to beg my esteemed primary care physician colleagues, some of whom are in this room today, please include questions about dry eyes in your inquiry from your patients. It is as important as their blood pressure. To my derm colleagues, the next time you see a teenager who's suffering from acne, think twice before you put them on a medication that causes such severe dryness that they suffer for the rest of their life. The list goes on. I didn't want to make this slide all-inclusive. We have colleagues in other fields that need to pay attention to what happens to patients when they put them on different medications. However, my main point here is that we are better together. Doesn't matter what field we specialize in. I need to learn from my primary care physician colleagues. I need to learn from my derm colleagues. Let's sit down, let's have multidisciplinary meetings, and let's become the doctors we were meant to be. We went to medical school, we learned about the whole human person before we specialized. We still need to be that way. I need to know about your fields. Please afford us the opportunity to tell you about ours. The patients are the same patients. Let's join forces. I beg to all the specialists in other fields, come to these meetings. I invited them. Some of them have, graciously accepted. I'll continue inviting them. And I would love to go and learn from them in their practices. And my main message today is to our esteemed Academy of Ophthalmology board members. Let's review some facts. This is statistically the most prevalent eye disease in the world now. All our colleagues in other subspecialties, cornea, retina, glaucoma, oculoplastics, neuro-ophthalmology, pediatric ophthalmology, all of their good work doesn't realize the potential they're working so hard for if the ocular surface is not healthy. This is a disease they all need to be concerned about. I invited all of them to this meeting. Ocular surface is the first and the last thing in eye care. Without it, without a clear window, you cannot see the beautiful view, no matter how well you work in other structures in the eyes or elsewhere. So my request to the board is simply this. Isn't it time for this field to become its own subspecialty? A field that has more patients than any other subspecialty. And there is no other subspecialty that is exempt to the health of the ocular surface for the work that they perform. One of the other main points I want to make here. My interest in this field got started way before any of the technologies in this room existed. It was 25 years ago, and I was a resident. And I was humbled when my wonderful mentors said to me, oh, it's in your blood. You can do this surgery in your sleep. And I was humbled by that. They said, oh, we're going to graduate someone in you that we'll go to ourselves. I was humbled by that. But I would go to the office or to the clinic the next day. I would see my patients where I had done a smooth surgery, and they didn't have exactly 20/20 consistent vision. The vision would fluctuate no matter how smooth the surgery had gone. That's when I started talking to my wonderful mentors and said, what's going on? And I started being involved in research in the ocular surface because I realized early on, doesn't matter how good of a surgeon you are. If the ocular surface is not healthy, your work is not going to produce the results that it deserves. The AAO has always taken the lead to organize our subspecialties. They've done a wonderful job. I am thankful to them. I am who I am because of them. I'm humbly begging them today. Please help us bring more public awareness to this disease. A disease that's chronic and silent, and if untreated and undiagnosed, becomes debilitating to patients. I also want to beg the Academy to let doctors teach doctors. Since when have we had industry teach us? In the field of dry eyes, is the only field when there's a new technology, the poor rep has to come to the office and present the technology to us and beg for a couple of minutes of our time to listen to them to see what the technology is doing. They're behind the 8 ball with us because the disease is not important enough for us. And they're behind the 8 ball because doctors don't learn from industry folks. Doctors learn from doctors. I didn't become a cataract surgeon by learning cataract from the company that produced the phaco machine. I learned it from other doctors, and then I chose my phaco machine. The knowledge, the know-how, the passion for a disease has to be transferred from doctor to doctor, not from industry to doctors. This field needs to be its own subspecialty. Doctors need to teach doctors. And the industry can come to our aid by providing the technology we need and the tools we need to treat our patients. I hope our message gets heard. This meeting was put together to deliver this message mainly. In terms of how I treat my patients, I'll talk more about it when I'm treating patients there, but a simple workup, I think it's best that I leave this when I'm treating patients and we can go over my method and my tools in my office. I want to end my talk here by saying we need more eye care professionals to join us in an effort to bring the serious attention to a serious disease that is causing major distress in patients who deserve better care. This meeting was a small effort on my part to deliver that message today. And I'm so humbled with your gracious presence here to help me deliver that message. Thank you.
So passionate. So I want to add just, a little tidbit. The subspecialty, we were talking about it and we were like, we need to get so many practices to get involved in this. And the sad reality is the number of practices around the United States that are actually really taking care of dry eye. I mean, one hand, maybe two hands. That's the sad part of this. People are dabbling in dry eye, but it really is like a subspecialty. There is a lot to it. So we have a lot of work to do. So it is now my distinct pleasure to introduce our special guest, Cheryl Jennings. She's an Emmy award-winning journalist with an illustrious career spanning 45 years in radio, television, and online broadcasting. Her commitment to storytelling and reporting has earned her 9 Emmy Awards, and she has been recognized with 7 National Gracie Awards by the Alliance for Women in Media for her compelling stories on women's issues. For nearly 4 decades, Cheryl was a prominent figure at ABC TV in San Francisco, where she anchored the award-winning 5 p.m. news for 28 years. Her dedication to community service has led to the raising of awareness and millions of dollars for numerous causes, from children with life-threatening illnesses to women's rights, domestic violence, veterans issues, mental health, and the landmine removal in war-affected regions. Her commitment to service extends to her role as a media advisor for several nonprofit organizations, including Roots of Peace, her current involvement in producing a documentary on the lost history of pediatric AIDS. Please join me in welcoming Cheryl Jennings, a remarkable journalist, advocate, and mentor whose contributions have left an indelible mark on the world of media and customer service. Cheryl?
Oh, thank you for that introduction. I think my remarks are going to be shorter than that. Thank you all for being here today. I'm really honored that Dr. Mosadi invited me to be here. My husband, Rick, is also here with me today. We are patients of Dr. Mosadi, and the young lady I'm sitting next to, Kate Shake, is going to be speaking shortly after me, and she has a story that will make you remember why Dr. Mosadi is doing this. It's incredibly powerful. Everybody talks about how this is really an eye disease. I didn't know that what it was. I was just, I just had dry eyes, right? I volunteered to be on this panel. I wanted to help Dr. Mosadi and my husband both want to use our social media platforms, whatever we can do to help share her message, because people do need to get the word out about why this needs to be a subspecialty. Once it's discovered, as I learned, it has to be managed every single day. And I do manage it with a lot of tools. And anything new that Dr. Mosadi discovers, I was really excited to see all of the vendors here today because I use all of your products. So I am grateful to all of you for what you do and for what you're bringing to help people like myself. It is debilitating. Patty said it's debilitating. Dr. Mosadi said it's debilitating. It is awful if you haven't had this problem. For me, in my former job as a news anchor for ABC, as a news anchor and documentary producer, I was in front of the computer for 16, 18 hours a day sometimes, and in the studio with bright lights and anchoring maybe 2 shows a day for half an hour to an hour, maybe 4 or 5 shows if I'm filling in for somebody. And that's a lot of time in front of those bright lights, air-conditioned studio, on the computer constantly and doing social media blurbs in between the commercial breaks. So always working and always trying, why can't I see? Why can't I see? And I looked like I was always tired and my eyes were bloodshot. Um, I, it's not a good look for somebody who's supposed to be a trusted position of authority. So those of you who have been in that position, you know, when you look tired and haggard, it's just, people just like, oh, what's wrong with you? So sometimes when I was writing my documentaries at home, I would have, the pain was so bad in my eye, I would have to just sit there and hold it like this and try to write with one hand. And I mean, it was just horrific pain and I didn't know why. I could not get enough moisture in my eyes. I also, really scary, it affected my ability to drive, and especially at night. So that's not a good thing when a busy person has all of those things affecting them. So I also had LASIK surgery many, many years ago before anybody knew the real consequences of what that does to your eyes, which made my eyes even drier. It was great at the time. I loved it because I was doing international traveling. And so the ability to see without glasses or contact lenses, it was worth it at the time. Now I'm paying the price. I knew I needed help. I didn't know where to get that help. I didn't have anybody in my ophthalmology field who could tell me what was going on with me. But a friend of mine whom I'd met through interviews, a federal judge, said she was complaining about her eyes and how she had gotten better. And I said, oh, I have that same condition. And I said, well, who do you see? And she said, Dr. Musati. And I said, okay. So I called Dr. Musati's office, got an appointment. And that was the beginning of the change for me for the better for the rest of my life. I'm sure that she has preserved my vision because of what she taught me. But it's a lot of work. The first tools that she and her office team used on me was this little squeezy thing. And those of you who know, that's not a scientific term, but it's like a pair of tweezers and they just press to see if you can get the oil glands out of your eyes. Somebody knows the name of that tool, but the expression, but it's a squeezy thing to me. And so they would do that and nothing would come out. I mean, it was so painful, even with the drops that are supposed to numb the eye, nothing happened. So it took many, many, many months of all of that and the eye drops and the hydro eye, the vitamins and the Lipoflow, and then the IPL. I did all of that and eventually it started to work. My last checkup was the best checkup I've had in years. She got oil to come out of almost every single gland, which was like a miracle to me. So thank you. I was so relieved that it finally worked because it's enough to make you want to give up. The hot eye compressions at night. Oh, do I have to do this? You know, the eye masks, all of that. It was worth it. The important thing for me was her knowledge, but more importantly was her empathy and compassion. She listened to me and she spent time with me. And my husband and I have both, when we were happy to wait and wait and wait for her because everybody wants to see Dr. Musati and she will take her time with us. Nobody leaves, they want to see Dr. Musati. So it's worth the wait to have somebody who will listen and value what you have to say. Her empathy was more than I can even express how important that was. And so I'm very, very grateful for that. The other thing that compounded my problem was we recently moved to Nevada, which is even drier than the lovely Bay Area. So now I have a new problem. So I can't find anybody in Nevada. You were talking about how nobody's around. And they have things online that say, oh yeah, we have a dry eye clinic. But then I look at the list of things and it's none of the things that you're hearing about today. It's a lot of eye drops. I talked to my primary doctor and I said, I have this dry eye disease. And he looked at me and he said, what's that? And he wouldn't even refer me to somebody who knew anything about it because he didn't know anybody and he didn't know anything about it. And he's got 30 years in the business. So I thought, oh boy, I'm in trouble. So we now fly back from Las Vegas to at least twice a year, more if we can, to get treated by Dr. Musati so that I can keep that momentum going that I had with her. The kind of compassion we found with Dr. Musati is so rare. And I hope that each and every one of you has that for your patients and your business clients. It's really important for me to be here to support her And I will do whatever I can. And also, I'm hoping that you will also help her share the message that we really need to treat this like a disease to save people's sight. So thank you for listening to my story. I appreciate it. And thank you, Dr. Masadi.
These stories happen every day. The part about waiting, as an administrator, so you can only keep them waiting so long. So I just have to say that. Kate Rader Shake. Today we have the privilege of hearing from a remarkable individual. She has faced a lifelong challenge with dry eye disease. Kate is not only a patient of Dr. Lily's, but she also wears the hat of being a devoted wife and a loving mother to 2 young children, aged 3 and 6. She's a partner at the world's largest legal recruiting firm, bringing a wealth of experience from her former career as an attorney. She graciously joins us today to share her personal odyssey of living with dry eye disease, shedding light on the experiences, the challenges, and triumphs that have shaped her past. We are privileged to hear her story and the insights she brings from a unique perspective. Please join me in giving a warm welcome to Kate Rader Shake, a testament to resilience and strength in the face of life's challenges.
Well, that was very kind. Thank you. Thanks for having me today, you guys, and I'm going to be watching that clock. I have suffered from dry eye my entire life. I remember using eye drops and eye gels as a kid. Once I started wearing contact lenses, that became magnified dramatically. Interestingly, I was never diagnosed with dry eye. I saw my eye doctor annually, if not more frequently, because my vision is garbage. And she never said a thing, despite the fact that I reported that I felt dry. I now have access to my old records, and it is clear that my eyes were significantly dry enough to be clinically visible, but nothing was ever said to me. As with a lot of different kinds of pain, you just kind of get used to it. It was my baseline, and it didn't meaningfully interfere with my life. That all changed 2 years ago this month. I developed a bad cold. I was taking Sudafed, basically around the clock. My eyes dried out basically all the way, from what I can tell, and I have not yet recovered. In December 2021, I was diagnosed by the UCSF Proctor Clinic with corneal neuropathic pain as a result of my dry eye. This has left me disabled. I'm 42. I'm otherwise in good health. As noted, I'm a wife and a mom and have a very busy career. But it has become extremely hard for me to live up to all of the obligations that those roles cause. My pain is not bad in the morning. So that's when I try to spend as much time as I can with my kids, because I'm not cranky or trying to distract myself. As the day wears on, my pain becomes increasingly unbearable. By nighttime, I'm often in 6 out of 10 pain, unless I'm icing my eyes, have eye gel in them, or am asleep. That means I'm often short of patience with my kids at bedtime, which kids of the ages of 3 and 6 can sometimes cause a lack of patience regardless of your health status. Sometimes I can't even read to them, which is something that when I became a mom, I love books. I read probably a book every week and a half, and not being able to share that with them sucks. It also means that I say no to most invitations I receive for evening parties or dinners out with friends. It's partly because I'm likely to be in a room with forced air that's going to cause things to be even worse. And it's partly because I'm embarrassed. When I'm out in the evening, I'm blinking heavily. I'm trying anything I can do to get some oil onto the surface of my eyes. And it feels embarrassing to me. This has left me isolated and quite often a little bit depressed. I have tried so many interventions. I wear scleral lenses. I'm wearing them right now. I fill them with refrigerated saline solution and autologous serum tears. I use AST 7 times a day. I use Mibo. I use Cequa. I use Tyrvaya. I use fluoromethalone. I take 300 milligrams every day of Lyrica, which causes word loss, among other fun symptoms. I have previously been on low-dose naltrexone, Lotemax, Cymbalta, amitriptyline, nortriptyline, carbamazepine, Celebrex, Trileptal, and Zedra. I have had 4 nerve blocks at the UCSF pain clinic. I've tried a ketamine infusion, which was not a pleasant experience. On nortriptyline, I gained 25 pounds over the course of 3 months and developed painful cystic acne at the age of 42. I've had some really dark moments trying to treat this condition, which resulted from my dry eye. I've read all the books, The Way Out, the Pain Management Workbook, Managing Pain Before It Manages you name it, I've read it. I try to do all the homework I possibly can. My Schirmer and my T-Butt are usually 1. My eyes are extremely dry, and the neuropathic pain on top of it is unbearable at times. When my eyes first dried out in 2021, I saw an eye doctor in the community, not at UCSF. She told me that the pain was in my head and I should seek psychiatric care. I left crying. Was it all in my head? Would anyone ever understand my condition? I didn't know that dry eye existed as a diagnosis, and I did not know that dry eye doctors existed. Finding Dr. M has helped me to feel some hope again, that this pain hopefully won't be my lived experience forever. We've done IPL, which has helped. We tried Procara. She's seen that I have meibomian gland dysfunction. They are wildly deteriorated. Not only has she helped me, but she has helped me to feel seen after I felt gaslit by a lot of the previous doctors I saw. It is possible that I live with this debilitating neuropathic pain because I wasn't seen quickly enough for my dry eye. I am part of a Facebook group of people living with corneal neuropathic pain. There aren't many of us. Many of my peers in the group are constantly asking for recommendations for dry eye doctors where they live, and they simply don't exist. It's worth noting in a fit of darkness here that several of the members of my neuropathic pain group have committed suicide since I joined in 2022. Not all of them have this pain because of dry eye. A lot of them have it because of LASIK. But a lot of us started out with untreated dry eye and fell off a cliff into this disease. Just yesterday, a woman from the group reached out to me because she was having a really tough day, and I guess I've become kind of the mom of the group. I talked to her for 45 minutes that I did not have available in my workday yesterday about why it was worth fighting through the pain for her 5-month-old baby. It's not just trigeminal neuralgia that is the suicide disease. I want to close by saying I'm okay. I'm still here. Sometimes I'm even good. I went out to dinner with my friends last night and it was lovely. I do my job, which I really enjoy. I try to meet friends usually for lunches instead of dinners when my pain is less of a burden. But there's no doubt that my life is much darker and has way less joy than before dry eye led me into this path to corneal neuropathy. Addressing the dry eye helps in a meaningful way. My T-Butt was 2 last time I saw Dr. M, so that's a win. I have more good days since I met her than I had before. I will continue doing everything I can possibly manage to get my condition under control with the help of my medical team at UCSF and with Dr. M. But we need more Dr. M's out there doing this work, or I worry about both the physical and mental health of those who come after me. Thank you.
If that doesn't touch you, oh my gosh. So we have many patients like this in our practice. The suicide thing is real. We had a patient in a study that was on a drug that was actually helping, but then when the study was over and they couldn't get the drug, they were very upset and suicidal. We had to send somebody for a well check on the patient. This is happening, and it's a dark mark on our community, if you will, that we're letting this happen. I'm sorry, but there's something wrong with the fact that patients come and go from physicians and no one lets them know, and that you get to where you are today. It is not okay. So with that, maybe to a little lighter note, I don't know. Dr. Frank Bowden, the third. He is the founder of Bowden Eye and Associates, who I have the great pleasure to work with. We founded that in 2001, but he was in practice prior to that. The practice specializes in comprehensive eye care, custom cataract surgery, refractive and LASIK procedures, glaucoma surgery, dry eye treatment, corneal transplantation, and addressing corneal and external diseases. He's renowned for his expertise in dry eye disease, drawing patients from around the world, actually. It is amazing for us when we get a patient that calls and says, I can't find anyone, and I was told you're who I should come to. So that is what's happening because we do not have enough of providers taking care of these patients. He completed a highly competitive cornea and external disease fellowship at the prestigious Wills Eye Hospital. He was born and raised in Knoxville, Tennessee, and he's a devoted Tennessee Volunteers fan. He graduated summa cum laude from the University of Tennessee, earning Phi Beta Kappa honors, and attended his MD and attained his MD in 1979 from a Meharry Medical College, where he was the class valedictorian. He is very smart. I know he was a big nerd back then. He's come a long way. His postgraduate training encompassed an internship and ophthalmology residency at the U.S. Naval Hospital in San Diego, California, followed by a distinguished fellowship in the cornea and external disease at Wills Eye. And he ended up in Jacksonville, Florida, where we are very lucky to have him as part of our community now. So, Dr. Bowden.
Thank you for the gracious introduction, and it's a pleasure to be here. Thank you, Dr. Masadi, for the wonderful invitation to join you today. My presentation is going to address the tools of ophthalmology. He's going to bring it up. That gives me a moment. So basically, we have a comprehensive dry eye practice that allows us to essentially have the full panoply of options, medical therapies, surgical interventions, as well as procedural offerings to allow us to take a kind of a targeted approach. We identify the underlying mechanisms that contribute to their dry eye presentation, and we are able to implement the appropriate targeted treatments that allow us to get the best outcomes. Very good. So again, my talk is on the tools in developing a dry eye practice and my disclosures. And as far as the need, is there a need for dry eye related tools? Well, as you've heard earlier from Dr. Masadi, the dry eye disease is chronic, progressive, and very prevalent, and it is associated with a discordance of signs as well as symptoms. Oftentimes, patients have very few symptoms, but they have major significant dry eye findings. Many of our eye care provider colleagues rely on clinical diagnosis and palliative therapy to deal with patient symptoms. And just like with any chronic progressive disorder, patient compliance with our dry eye care is oftentimes very poor. So dry eye disease certainly is impactful in a negative way in terms of visual acuity, visual quality, and it certainly is the source of contact lens intolerance among many of our patients. Cataract and refractive surgical outcomes can be adversely impacted as well. And as was earlier noted, it does have a significant impact on work productivity. Now, dry eye care is best managed in the same evidence-based fashion that we approach glaucoma. And that involves the use of targeted integration of diagnostic as well as therapeutic technologies. Just as in glaucoma, we look at structure and function of the optic nerve and rely on tools to allow us to measure those parameters. And we also rely on specific therapeutic tools to address the underlying mechanism of glaucoma, whether outflow obstruction at the trabecular level or at the transconjunctival methods to bypass. So the selection of diagnostic tools for dry eye disease management have been guided by the consensus reports of the second dry eye workshop in 2017, as well as the MGD workshop in 2011. And these identified parameters that allow us to obtain measurements or metrics that allow us to evaluate and manage these disorders. In the case of the dry eye workshop, dry eye disease was defined as a loss of ocular surface tear film homeostasis. And these have been characterized as tear film instability, tear film hyperosmolarity, ocular surface inflammation and damage, as well as altered corneal sensitivity and discomfort. The MGD workshop defined altered meibomian gland structure and function, and identified terminal ductal obstruction and gland atrophy to be parameters that we can identify and measure, as well as the appearance or alterations in meibum secretion quality. So the selection of diagnostic tests should allow us to provide clinically useful metrics that allow us to evaluate and manage dry eye disease. And I won't list all these, but all these are metrics that we use in our practice to establish the state of their dry eye disease, the level of inflammation, the level of hyperosmolarity. All these things are measurable parameters that allow us to characterize and identify the underlying mechanisms contributing to their presentation. These metrics are essential for an evidence-based approach to dry eye disease and meibomian gland dysfunction. It allows us to categorize the state of their disease and the clinical severity. It allows, as I mentioned, targeted treatment approaches. It facilitates longitudinal monitor of disease. It allows us to assess the response to our interventions that are therapeutic. And it allows for effective patient education, as well to enhance compliance and to gain the patient's trust that we understand what's going on and we have an effective treatment plan, and that they can comply with and expect some improvement. Now, the selection of these tools also takes into account the acquisition and operating costs of these technologies, along with the return on the investment. Insurance coverage has to be considered. Patient acceptance to self-pay services have to be assessed and managed. In some technologies, a CLIA or a clinical laboratory license has to be obtained. Office space and device footprint. It's important to consider with workflow and space in an office that, particularly with satellite offices, we can't have all the technologies in every place. So these are all things that have to be taken into account. The time invested for educating staff and to essentially devote to patient education also has to be taken into account. There are some available technologies that allow for multi-platform devices that allow multiple parameters to be checked with one device. And so there's some opportunities for savings as well as convenience and workflow efficiency there. Now, as far as the therapeutic tools that we use, they are typically targeted toward managing aspects of meibomian gland dysfunction, which has been identified as the most common factor that we see in dry eye presentation. Now, these tools address multiple facets of meibomian gland dysfunction. For example, with blepharoexfoliation, that's designed to mechanically debride the lid margin, and we have BlephEx, as well as the Zocular eyelids system treatment. We have meibomian gland probing to address gland obstruction, terminal gland obstruction. And we have the Maskin probes and compressive forceps that are designed to mechanically evacuate the oil glands that have been obstructed. Thermal pulsation therapy, we have a number of effective tools in the LipiFlow, the Sustain iLux, as well as the TearCare systems. Photofacial therapy for managing rosacea has been very helpful, and we have the intense pulse light therapy, the intense regulated pulse light therapy device, as well as low-level light therapy. All these procedures are designed, again, to reduce inflammation. They're designed to halt the progression of meibomian gland atrophy that results with unchecked gland obstruction, and it's designed to improve gland function. Now, the selection of these tools also should be guided by the practice focus. In the dry eye disease aware practice, there may be a level of disinterest in getting into it, and a level of and a desire to not invest a lot of cost. And so clinically, the patients can get a speed questionnaire to assess symptom severity, assess osmolarity, which is identified as probably the most reliable diagnostic indicator of dry eye disease. And a Q-tip and transilluminator can help identify expressible glands and gland architecture. With a dry eye collaborative practice, I would add to the above the Inflammadry test that allows us to assess ocular surface inflammation, meibomian gland evaluator that allows us to assess the number of expressible glands that are yielding secretions with minimal pressure or with the force of a normal blink. And there are technologies to allow us to actually visualize the meibomian gland architecture with meibography and external photography. I find external photography is clinically very powerful because it allows us a tool that allows for patient education right there on the spot. In terms of intervention, collaborative practices oftentimes are willing to embrace gland or the blepharoexfoliation exfoliation treatments, as well as IRPL, IPL, and with gland expression. With the comprehensive dry eye practice, as we have all the above, in addition to lipid layer thickness measurement or tear film interferometry. We have the iTrace device and corneal topography that allows us to measure corneal surface aberrometry, higher order aberrations of the surface resulting from an unstable tear layer, as well as placido disc imaging that allows for a nice visual representation of the unstable tear film. Therapeutically, we have, in addition to the above, thermal pulsation with the iLux, the LipiFlow, and the TearCare systems. We do meibomian gland probing on any patient who demonstrates fewer expressible glands than they have anatomically present. We also use amniotic membrane, cryopreserved, as well as the dehydrated devices. And we also treat conjunctival chalasis with a plasma pen as an off-label treatment at this time, but very promising and very useful for mild cases of conjunctival in the office, and as well as low-level light therapy that has been very helpful for those patients who, because of skin pigmentation, are not candidates for IPL therapy. So in closing, I would say that there are, as you can see, a number of tools and technologies that are available to us today. The selection should be based not only on metrics, but also on practice focus. Each practice has to kind of define how far they want to go, how much they want to invest, how involved they want to be in the dry eye process. But clearly, the goal is getting patients seen. Either you take care of it or you refer to a colleague and get the patients taken care of. An evidence-based approach to care is, I find, more effective, more rewarding, and patients are generally more receptive to it as targeted treatment recommendations are made. And engaged and educated patients, in our experience, has generally been far more compliant and, again, very rewarding for us. And that concludes my remarks. I appreciate it.
And we now will have Dr. Sarah Darbandi. Dr. Darbandi in journey in the world of ophthalmology began with Medical School of West Virginia University, followed by a residency at West Virginia University Eye Institute. Dr. Darbandi's passion for corneal transplantation and refractive surgery led her to pursue a fellowship in Albany, New York, specializing in cornea and refractive surgery. In 2012, she joined Bowden Eye, and we've loved having her. And she's become a pivotal figure in our team. And she serves as vice president and our first partner in the organization. Her expertise encompasses a wide range of ophthalmic care, from custom cataract surgery, corneal transplantation, ocular surface reconstruction, refractive surgery. She offers aesthetic treatments, including Botox, fillers, brow lifts, upper and lower blepharoplasties, lid lasering, surface skin resurfacing. And notably, she's renowned for her dedication in addressing dry eye disease, and is not only a speaker in this field, but she's also one of the founders of Dry Eye University. And we are privileged to have her here today with us.
All right, we did it. So I was asked to speak about the role of nutrition and supplements in dry eye disease. And so this talk is not just going to be about the fish oils and omega-3s that we're all familiar with. I think there's a few points to touch. So as Patty said in that wonderful introduction, I really enjoy doing aesthetics. I think that there's a lot of parallels in the world of aesthetics and ophthalmology. There's a lot of skin treatments that are chronic. The vitamin supplementation and things that we do for that way, you know, there are parallels in the ocular surface world that we'll talk about, fixing the skin layer of the eye and protecting it from oxidative stressors and damage. And so by presenting this, you know, concept to patients about supplements in this kind of different way, you know, making parallels to other things that we take supplements for, it, you know, can be more accepted by patients. They could be more receptive to the chronic nature of the disease and the chronic treatment, because not every patient really understands how bad this disease can be, and they need to be on long-term treatment. And so what we understand about ocular surface disease, so much of it does come from inflammation, oxidative stress. We have metrics that measure this. And so it makes sense that we recommend things that patients would take that helps the body and the natural immune system to tone that down and to help the body kind of work against this stress, so the patient is helping themselves. And so in any oxidative stress, there's this upregulation of inflammatory cytokines, the IL-6, 8, TNF alpha, to name a few. And so they're not just eye drops, but these nutritional supplements that we take to protect our organs, to ramp up our immune system when we're sick, things in that way. We should think about having patients take these more regularly, you know, to be able to prevent the stress, the free radicals that are probably produced, and having an effect on the ocular surface. So as I was kind of doing research in this talk and looking at studies and things in that way, I think that there's a few things that we may be missing, that maybe we want to start doing some more testing for vitamin deficiencies for these patients. So in the time that I have allotted, I'm going to talk a little bit about vitamin A, B12, C, D, and I'll touch on the omega-3s that we're all familiar with. Vitamin A deficiency is no longer something that's found in third world countries. These are things that we have to think about even now. Vitamin A deficiency in developing countries has always been thought to be one of the most preventable causes of blindness. And these days it can be associated with bariatric surgery. And there are a lot more patients out there having these procedures than you may realize. And vitamin A is one of the fat soluble vitamins that may not be absorbed. Those patients may not be compliant with their regimens after the surgeries. And so it's going to cause a significant keratinization of the conjunctiva. It can cause epitheliopathy of the cornea and even ulceration. as I'm saying these out loud, I think of so many of the dry eye patients that I see that have keratinization of the lid margins, difficult with ulcers, erosions, dense staining across the palpebral fissure. And so it's something for us to really think about, maybe even start measuring in the clinic to see if this process is more prevalent than we think, because it's not just in developing countries. I think that it's in our clinics. There is a product called Hyalinite ointment that does have vitamin A as an ingredient. And so this is something that I think can be a treatment to address this deficiency, if we can get the metrics and sort that out. Vitamin B12 is such an important vitamin, and it's a cofactor in DNA synthesis. And it can be deficient for patients that have a vegan diet that aren't taking supplements regularly. Vitamin B12 has a role in the synthesis of myelin. And in medical school, the patient that presented with the B12 deficiency was the older senior patient on a tea and toast diet, not getting any nutrients. But these days, a lot more patients can get a vitamin B12 deficiency because really these days, there's no longer as much B12 in the foods we're eating. Meat is not a source of B12 as much. People say that they should be supplemented on a daily basis for everybody because it's not in the foods that we eat any longer as often. And so we know that the B12 deficiency can cause optic nerve atrophy. I've seen those patients and demonstrate on visual field testing and got them to their primary care doctor for B12 supplementation, and they improved. And so it's out there in even regular patients on, regular diets and things in that way. And so B12 supplements we know are used in neuropathic pain, patients that have diabetic neuropathy, trigeminal, and postherpetic neuralgia. There may be a role for it in these neurosensory neuropathic pain conditions that we see in the clinic. Vitamin C is present in high levels in the tear film to provide a strong antioxidant defense. What if patients are deficient in this? Maybe not everybody has the vitamin C levels they're supposed to. When I'm treating a patient with a corneal ulcer, one of the supplements that I often recommend besides doxycycline to stop the collagenase activity is a gram of vitamin C daily to help with the collagen synthesis, the healing of the corneal ulcer. And I feel it's important in that process. I sometimes wonder if collagen supplements would be helpful in that way too. And then there are studies out there, though limited, that show that when you supplement vitamin C, there can be an improvement in the Schirmer test score, the breakup time, and the fluorescein staining. Vitamin D is another fat-soluble vitamin, and it regulates cellular proliferation, differentiation, other cell functions, and enhances the epithelial barrier of our skin and possibly of the cornea by protecting the lipid component of the tear film. And so there are studies as well with vitamin D and the supplementation that shows that it can improve corneal staining and dry eye symptoms after a period of time. And so I think with any supplementation that we're recommending in our office, it's always a education piece of this is a chronic condition. This is a long-term treatment. This is not just meant to sit on your counter and look pretty. It's every day consistent to help. And again, this is a concern in patients that have had bariatric surgery that are not absorbing these vitamins. There may be more people out there that have these malabsorption conditions. We recognize, of course, that omega-3s are important. They're anti-inflammatory. These proteins, the resolvins and protectins, are derived from the omega-3 fatty acids, and they basically stop the infiltration of these white blood cells to the corneal surface that would then infiltrate the lacrimal gland, make the lacrimal gland not produce as many tears, probably encourage other inflammatory processes. And it helps to improve the function of these macrophages that fight disease. It promotes the corneal epithelial integrity and the tear production. It helps to potentiate the effect of nerve growth factor in stimulating nerve regeneration as well as epithelial proliferation. And so studies also suggest that it can help keep that meibum in its lower melting point state, where it will be in its more fluid state, where somebody blinks their eyes and liquid oil comes out like olive oil and isn't just stuck in the glands like a thick wax. In our practice, the nutraceutical that we recommend is Hydri. And so after going through some of those vitamin supplements, we find that Hydri really has really almost everything that I touched on here. DHA is the big important fatty acid chain. It's got the B6 antioxidant component. It also has something called GLA, which is not found in fish or flaxseed oil, but helps to promote anti-inflammatory components. So in summary, nutritional supplements are well known to decrease inflammation and be neuroprotective. We take these regularly to boost immune system, to help with our skin, nails, those types of components. I think that it's something that we need to consider more in more early treatment plans with patients as an appropriate supplement with their tiers and the other tools that they're using. And the Hydri supplement, of course, very inclusive of the nutrient supplements. And that's why we've chosen it for our practice and have for the last 11 years. So hopefully that inspires you to maybe even look for more of these types of issues in your patients. Thank you.
So we're just a little bit behind schedule, but we're going to push forward, okay? And then try to make up a little bit of time. So, I was asked to speak about, for my contribution, the administrator's role in, bringing dry eye care to a practice and growing dry eye care in a practice, and really just being the champion, if you will, for these patients. At the end of the day, what happened? You had it. At the end of the day, you know how to get it back. Sorry, y'all. We are not IT people. There's a company out there called Codex IT. We need help over here.
Need a team member.
Oh, we're up now. We're good. Thank you. There you go. Thank you. You're so good. At the end of the day, we're the champions for our practices, and we have a responsibility to who? Our responsibility, and the reason we're all doing what we're doing, there's one end game here, and it's the patient. And I think sometimes the patient is lost in the process. Sometimes it's egos where, a doctor gets in the room and a doctor's treating what a doctor wants to treat instead of meeting the needs of the patient. There's a lot of different things, but I found this image, and this image really spoke to me, and I hope the image doesn't mean something bad that I just didn't see. You never know these days. But what I saw in this particular image was the head, the heart, and the hand, right? And now there's some feet and stuff there too. And I don't know what everything else means, but ears for listening. We need to be able to listen to what people are asking for and meet the needs of the patient. Hands for helping. We've got so many gifted physicians who are just brilliant, and we need to be able to take care of the patients. And then the hearts for the empathy. There's an empathy component to this, which is big. Being able to put yourself in someone else's shoes. Just because you have not personally experienced something doesn't mean that it's not real. And I think for these patients, I think, Kate, you spoke about the fact that, no one listened. And at one point they even, suggested psychiatric care. And we've seen this, patients that come in our practice and have been to many, many different practices, and no one would listen. And when we sit down and we start educating and we're taking care of them, they're like, why haven't I heard this from someone else? And that is so sad, because when you think about it, it's like, duh, it's dry eye disease. How hard could dry eye disease be? Because that's what the lay person out there, the patient, thinks. They don't understand why they keep getting skipped over and no one's listening. You can go look at charts, and you can look at chief complaints and charts, and you see time and time again in the chief complaint, the patient expressing signs and symptoms of dry eye disease, then they're scheduled for cataract surgery. We skipped right past what the patient's needs were, went to what we wanted it to be, to meet a volume, a quantity, or whatever. And not that the patient's going to get bad care in their cataract surgery, but after cataract surgery, what's going to happen? They're still going to have the same symptoms they started with before surgery. So for an administrator's role, there's some successful integration components that are very, very important. And I think this is important. And today's program, I think, leads at those who lead by example and demonstrate passion for what they do, make it much easier for the followers to do the same. So whether you're the leader in your practice, the leader of an organization, a physician that's in charge of a practice, whatever, do it with passion and do it with detail, because it is about the details. And remember, using the ears by listening to the patients. That's so important. So I looked at, it's the doctor, staff, and patient relationship that matters here. And this is important because it is it's a relationship. I know I often hear Dr. Bowden say to his patients, we're in this together. You start worrying when you see me start worrying. Until then, we're in it together. And that's important because everything within dry eye disease requires the patient's acceptance as well. It is their body, it's their condition. They just need to know what to do, and they need to be educated in that process. So if in this whole relationship circle, shared beliefs, we have to work with our practice, we have to work with the industry, and getting those shared beliefs. And I do believe in the dry eye space, there's been a lot of chaos that has been created within the space, whether it's a competitive force because entities are competing against each other for space. And remember, I said earlier, it's a puzzle. And there's pieces of the puzzle that fit together to treat these patients. There isn't one single thing out there that's going to solve any dry eye disease patient's problem. And early on, we saw that. I remember having multiple arguments with reps who would say, can you stop talking about the other stuff and only talk about what we're doing? And it's like, but your device, your piece of equipment, your product's going to sit on the shelf and collect dust when it doesn't work on its own. So you either start working together or it's not going to work at all. So the relationship is very important, having the compassion. That patient's going to come in, and these patients are not easy. It takes time. You have to listen. Sometimes you backtrack. Sometimes you re-educate. Sometimes you reshare. Sometimes you show those metrics Dr. Bowden was talking about. Sometimes the metrics are better and the patients see hope in that better measurement. Then the next visit, they come in and they've been set back. Because sometimes when they get better, they back up on what's their responsibility and the responsibility of home care, whether it's a nutraceutical, whether it's a lid cleansing, whether it's a warm compress, whether it's a medication, whatever it is, it requires, this is going to be a lifelong thing for these patients. It's not a one and done. Remember, it's the disease, so there is no cure. And that's the important thing. We're managing it. Being present, not being dismissive. Sometimes people are dismissive. Doctors are dismissive. We've had it in our practice before, and they no longer work in our practice because they were dismissive of what the patient's needs were. You've got to develop that standard, develop those beliefs and the shared beliefs, and then work together to be consistent in those natures. The mutual respect, the knowledge and experience is everything. A patient can tell what you believe in. If a provider says, you might want to try this, what does that mean? You might want to try it. Order it for the physician, for the patient, because that's what the patient needs, not you might want to try it. Confidence with humility. When it doesn't work, when something doesn't work the way you wanted it to work for a patient, you've got to explain why it didn't work that way and why we need to now go on to something else. That's why that toolbox is so important, because never, ever is one treatment going to work for everybody. So, I can remember early on, LipiFlow, and, LipiFlow, we have IPL. Is that going to hurt each other? And there was this bouncing back and forth. And we were like, they don't do the same thing. Can we stop that? We need both, right? We're not competing against each other. This is all very important. The personal chemistry, you're not always going to have patients who are personable like these ones today. Right? Some of these patients are real jerks. They're not happy people, and they show it when they come in. They're rude to your front desk. They're rude to your technicians. They're always nicer to the doctor. And then they start being rude again when they get back to the front desk. But we've got to develop a little bit of chemistry to take care of them. Honesty and integrity. You cannot promise people something that doesn't work. Trust and confidentiality. Very important. The patient's got to trust you if they're going to try what you want them to try. Opportunity to learn. Learning's everything. We learn every single day. I learned a couple of new things so far today. You're all going to learn more in these next sessions. And then affordability. We have to make it affordable for the patients, but we also have to understand the nature of the beast and the business, right? We can't give stuff away because we've got a business to run. So it's important that we understand that portion. Focus on these critical areas for success. This is my thoughts. Education. From the provider to the front desk, the counselors, to the technicians, to the patients, everybody, and it's constant. Providers come to Dry Eye University, and our program was designed, and it's a much different program than this, but it was designed in a pretend everybody knows nothing. We're going to teach the multi-factors, every single aspect of it, because sometimes people don't admit what they don't know, whether it's ego or whatever, but we all need to get to the nitty-gritty. The standard of care, develop a standard of care in your practice and follow it. Be very consistent with it. Pricing, get your pricing right, know what your market will deliver. Don't lowball this. Start on a higher level. You can offer introductory prices to kick off, but keep your prices up. Consistent processes and the toolbox that Dr. Bowden talked about. You need this. You need almost everything in this room. You need everything in this room and then more to make it be successful. If you were treating glaucoma or cataract surgery, you know what you got to have. You got to have an A scan. You got to have a phaco machine. You got to have IOLs. It's the same way with dry eye. Get the toolbox together. Any questions? Because we're going to go to the live demonstration area. And I think for time purposes, if you have questions of me or you have questions of any of us, we're going to be around in the room. Please feel free to stop us. And we're going to be going, you all have the schedules. So you're going to come up and say something. Okay. We're going to go around and we're going to be demonstrating certain things in the room. Make sure you visit each of these wonderful, wonderful vendors.
Thank you, Patty. Thank you, Patty. From here, we're about 10, 15 minutes or maybe 20 minutes behind the schedule. For the laser treatments, just to protect everyone, we're going to do it from a closet back there. I'm going to be mic'd so you can hear me. You're going to see the treatment, but the door will be closed so that you guys don't have to have goggles on. And you're going to see it on the screen. There's a lot of work that has gone into this. I want to give thanks to Jazz, who has orchestrated all this great technology for us to be able to do all this. So thank you, Jazz. So we'll do 3 treatments, and then we'll take a break, coffee, some goodies, some cookies and all that. And then after 15 minutes so 3 patient treatments, 15 minutes of a break, and then 3 more treatments. And then we're going to be joined by our esteemed colleague, Dr. Margaret McDonald, for her talk. And then the Q&A would be after that and reception to follow. Okay, in case you haven't looked at your timeline, I just wanted to summarize it. So I'm going to start the first treatment. So here we are with Kate. The first technology we're going to use is Intense Pulse Light Therapy, IPL, by Lumenis. I'm going to have Dr. Cork get to my left side, and as she's doing the treatment, I'm going to be talking about it. The Intense Pulse Light Therapy achieves many things as we treat patients. One of the most important parts of the treatment, as I discuss with my patients in my office, is the fact that our approach to dry eyes has to be multifactorial. First and foremost, you have these glands that are impacted by hardened sebum. You need to loosen the sebum and extract it. Basically, you need to get rid of the bad so that the good can come in. But once you do that, if you don't promote the production of the good oil, the gland gets impacted in no time. IPL is an attempt to decrease inflammation. There is a factor that's heightened in patients suffering from rosacea called MMP9. and that factor needs to be decreased. We need to improve the level of inflammation so that we get better blood flow to these oil glands for them to be able to produce better oil. Towards that goal, we put the laser grade goggles on the patients, even though this is intense pulse light therapy, just not through laser, but it's still we need to protect our patients' eyes. The way I do this, I prepare the patient by telling them that even though their eyes have goggles on, and I ask them to close their eyes even under the goggle, but it's still they're going to see a flash of light. So always educate your patients and prep them for the treatment. We do 2 passes. In my practice, we do the whole face. I believe that decreasing inflammation on the whole surface of the face is actually beneficial, even though the protocols usually are tragus, which is in front of one eye to the front of the other eye. I believe that, and many of my colleagues share in this opinion, that decreasing inflammation on the whole surface of the face is beneficial in these patients. Also, there are cosmetic benefits to doing IPL, and it would be odd to get part of the face looking better than the other parts. So for our female patients, we go the whole face. For our male individuals, we usually protect the facial hair by not going over that area. The way we do IPL, we do 4 initiations. The intervals can be anywhere between 2 to 4 weeks. And doing the initiation causes the inflammation to decrease enough so that after that you can maintain it. The maintenance, depending on the severity of the disease, could be bi-yearly or quarterly in our practices. I believe that it does need to be maintained at least bi-yearly. There are questions about whether we can treat autoimmune patients or not. I won't go into details of that, but just suffice it to say that I'm very selective, and depending on the individual case, I do still treat some of them with the technology. In severe debilitating cases, like what Kate talked about, this technology has helped us to bring more comfort to them. And also, because often we don't want to touch their corneas and put anything inside their eyes, the fact that we're protecting them with the shields is helpful as we are doing these treatments for them. To the audience, I would like to point out that even though we cannot have Q&A as we are doing the treatments, we are more than happy to answer your questions during the Q&A section after Dr. Margaret McDonald's talk from 4 to 5 o'clock this afternoon. We are now switching to the OptiLight. The smaller handle has helped us tremendously to get closer to the eyes and go around the goggles. Again, in my practice, selected cases, I would put laser grade protection shields inside the eye and treat the eyelids as well. My parameters when treating usually differ on the eyelid as opposed to the face. I also, for patients who come in with chalazions, I do give them an option. You can apply IPL on the chalazion before expressing it, and that often prevents us from having to cut on the sty or the chalazion. As we mentioned during the talks, usually we employ a multi-approach to treatment of dry eyes, as one without the other is incomplete. And IPL has been instrumental in helping us induce better oil production in our patients' eyes. In terms of skin typing, is crucial for this treatment that you skin type your patients. There are specific questionnaires provided by the company that you can use. And this treatment is safe on skin types 1 through 4. Beyond that, you need to be very careful. And also any patients of Asian inheritance, even if their skin appears white, they have more hidden pigment, and you need to be cognizant not to hypopigment rather young individual. With any cases that you're in doubt whether you're going to hypopigment or not, I strongly suggest that you do a test patch. And I usually, in female individuals, I choose the area right in front of their ear. In our male individuals, right in front of their hairline. The test patch would be a couple passes of the same parameters that you're expecting to use. In those cases, you usually would not want to exceed 10 millijoules. And seeing them in a week or two and looking at the area, documenting exactly where you did the test patch, and then proceeding safely if there has been no pigmentary changes. I will go around our patient here and exit the room and get ready for the next patient. Thank you so much, so much. We'll be moving next to plasma pen. For the plasma pen section, we're going to use bananas mainly because it would be very hard to use plasma pen on conjunctival tissue in venue like this. We're going to pass the cameraman and the mic to Dr. Darbandi.
So what I'm demonstrating here is called the Nuvissa plasma pen. And so we use this in the clinic for so many different applications. I'll hold this for now. For me, I do a lot of aesthetics, but that doesn't always mean lines and wrinkles and things in that way. Many times, it can be bumps that are more medical, patients that have a lesion around the eyelid that's irritating, a sebaceous hyperplasia mole, in a place where the dermatologist won't remove it. It's too close to the eye or things in that way. The other thing that it has great indications for is xanthelasma lesions. So for these patients that are coming in for that medical consult, I can use it on the skin for that reason. One of the most incredible indications for the Nuvissa plasma pen, which is off-label, but we're working on the FDA approval, is for conjunctivochalasis, which affects so many dry eye patients that have basically symptoms of being resistant to eye drops and treatments for their dry eyes because they have this redundant tissue that's taking the place where their tears should be or where tear supplements should be. And it's basically creating a situation where they can't hold the tears in the tear lake. They basically have nothing there to blink. And so what this is able to do is to create a very focused, direct heat on the conjunctiva that doesn't burn, singe, destroy the tissue like a hot temp cautery would, or something that's too aggressive. There's really no other device like this. And so to me, this is so important to have in the clinic for my aesthetics patients and for my dry patients. So I can show you with this banana how this pen actually works. So easy. Thank you. I carry this with me in the office, my pocket, so that if patients, you have a lesion, I can remove it today, no problem. And so for the conjunctivochalasis treatment, so simple. We're using proparacaine eye drops, leaning the patient back in a chair, lid speculum. I use a Q-tip and I do the plasma pen. It takes maybe 5 minutes. Patients have quick recovery time. In about a week, the conj is kind of re-epithelialized and looks tighter to the globe. So these patients are so happy with these treatments. They're tearing, these profound, patients that have all this watering. It affects them in every social situation. We're actually solving this problem with this Nuvissa plasma pen, quick and easy. So if we look right here on this banana device, the good thing about the Nuvissa that kind of sets it apart from other plasma pens or fibroblasting type pens is that it has a continuous mode. So I don't have to click a button every time I use it. So if I'm using it to treat let's say a lesion, I can hold the pen and it will basically create an ablation depending on how long I hold it there, where I can literally destroy a lesion. And if I'm doing a wrinkle, this banana doesn't have any wrinkles, I treat around it with these tiny little dots that basically for the skin are creating a little burn in the skin that's stimulating fibroblasts, collagen production, just like all the other aesthetics treatments that we do, like microneedling, resurfacing. We want to get into these deeper layers, and it's so quick and easy to do. And if I'm burning off a lesion, I just might hold for 1, 2, 3 and let it be destroyed. If I'm doing xanthelasma, I'm doing the treatment to get below the dermis, and then it's melting up that cholesterol deposit and basically getting rid of it. So, and on the conjunctiva, what's nice about this device is that you can basically do a little treatment of the conjunctival tissue, and you watch that conjunctival tissue just shrink wrap. And so it goes from being loose and baggy and taking up space in the tear film to being tight against the ocular surface. Anything that moves when somebody's blinking is going to create irritation. It's going to make their eyes look red, glassy. These are kind of the unappealing appearances that patients complain of. So to me, it's solved these problems that patients keep coming back and complaining of, that nothing else can solve the problem. Some people have asked, why not just use a handheld cautery tip? And I'll tell you, when I was in cornea fellowship, we used to do that to burn corneal vessels. And what it does is that it creates a huge damage to the conjunctival surface. The tip sticks to the tissue. Fibroblast energy is such a high temperature energy, but it's quick. So it's going to be more superficial, and I'm not touching this tip to any surface. It's just the little lightning bolt of energy that's touching the tissue. So my tip's not going to get stuck to the conjunctiva and then create this kind of rip of the conjunctiva in that way. And as you can see, it's super easy to use. It's quick. I mean, and it's also a great, addition to the practice, because in 10 minutes, to do somebody's lower eyelids, I'll charge, it's around $900 for conjunctivoplasty, $600, things in that way. So it makes a difference for the patient, and it's also adding value to your practice. Anything you want to add?
I would say too, there is a video up here playing on this, is Dr. Laura Pearman doing a CCH treatment. It's playing on the laptop up here if you want to see a real one being done. This is a no-brainer in your practice because the return on investment is huge, because it can be used in so many different areas. And if anybody wants to try it, they can.
Get here with it, but just bring that closer to the patient, and then you'll see the little lightning bolts. And so if you were treating a little skin tag or lesion, just hold 1, 2, 3 and get really close there. And so the reason, in techniques like CO2 resurfacing and things that way, for the skin, we're basically leaving space between, because we want the some of the epithelial cells not to be affected and to be able to repopulate the area. That helps with the faster healing. If you're doing a full ablative type treatment, you're going to destroy too much epithelium. There's not going to be healthy cells to re-epithelialize and heal quickly. So this is why the patients can heal from this so quickly, whether it's on the skin or on the conjunctiva. But everybody has patients in their clinic that they don't respond to drops. They're constantly having watering, tearing, and things that way. They don't have a duct obstruction. And so this plasma pen has solved the problem for many patients.
Thank you so much, Dr. Duggan. We're going to move on to the next patient and the next section. So the next technology is tear care. So as I said, if you don't get rid of the bad, the good doesn't come in. I'm going to stop talking, and I'm going to have Dr. Bowden do the honors here, and I will place the treatment pads. Just to explain to you why I'm treating most of the patients is because I'm the doctor with California license. So we want to protect our doctors. So I'll do the treatments, but I'll be quiet and we'll listen to Dr. Bowden.
Okay, thank you. So with the TearCare device is an effective thermal pulsation modality that has some unique features. For one, it's a portable device that allows for easy transport between satellite offices or room to room. You're not essentially tied to a specific treatment room for a device that is fixed in position. It also is desirable for those patients who may have some claustrophobia, in which they desire to avoid having both eyes covered for the duration of the treatment. It allows for dynamic gland expression, if you will, where after the applicators that have the thermal device coupled with the sensor guided heat source, it basically allows the patients to open and close their eyes during the treatment. And there's essentially a distinction that we make between functional meibomian glands and expressible meibomian glands. I didn't go into that, but functional meibomian glands are those which extrude oily secretions with the force of a deliberate blink. And so those functional meibomian glands that are able to release can actually allow for some expression during the actual heat application. So there are sensors in the applicators that allow for temperature control to allow for a temperature elevation to 41 to 45 degrees centigrade, which is sufficient to liquefy the semi-solid meibum secretions. And the typical treatment application is about 15 minutes, sufficient for liquefaction of the meibum secretions. And then this treatment is then followed by a manual expression of each lid with paddles. It's very well tolerated. The aspect of it that I think I like the best is that I can oftentimes have technicians do the application of the device to the lids and set everything up so that when I come in, I just do the manual expression, and essentially it lends itself to less disruption to your workflow in seeing patients. Okay. Can you tell us what you're experiencing right now? How does it feel?
Warmth on the lid and mainly around the hairline there, for sure. Very soothing and comfortable, actually.
I think it's helpful to persuade patients to consider it in that it's like a spa treatment. Any questions?
Later. Basically, I completely agree that it should be described like a spa treatment and like a jacuzzi temperature, so that patients have an appreciation, because the temperature is usually between 42.5 degrees and 45 degrees centigrade. Also, in my practice, I am interested in knowing how you do it, Dr. Bowden. I go by the severity of the gland and how hardened the oil is in the gland. If it is severe, I actually employ different techniques. Like I use this, I follow it by LipiFlow, and then manual expressions on top of that. That's a severe case. For a moderate case, I may combine it with, if there's rosacea, with other things. But what I'm trying to say is that it cannot be cookie cutter. You have to evaluate, you have to know the severity of the disease, because I often hear, I have patients who say, we went to so-and-so's practice and they did this technique or the next, but it didn't work. It's not that the technique didn't work. The doctor didn't know it needed more than that and didn't educate the patient properly. So you need to educate the patient, more is needed, and you need to determine what else is needed and guide them.
And to that point, that's why I emphasize in my presentation metrics are so important. It's important to know how many expressible meibomian glands are present. If the patient should normally have 25 to 30 expressible meibomian glands in the lower lid, and with expression of the lid with a Q-tip or your finger, you basically establish they only have 3 or 4 glands that are expressible, a thermal pulsation treatment is not likely to be as effective. And so consequently, that's when I made that realization of the need for meibomian gland probing to be included in the armamentarium that we have. And by opening up all the oil glands, it allows for maximum benefit of the thermal pulsation treatment, regardless of which technology is used, whether, sustained iLux, LipiFlow, TearCare, all of them require all of those oil glands to be open in order to get the best effect. And oftentimes in our practice, we'll do one technology initially with probing and maybe the BlephEx or Zest treatment, but we'll combine them and we'll do the blepharoexfoliation, the probing if necessary, and the thermal pulsation treatment all at one time. And I do have some patients who are enlightened, who get it, who basically understand all the component parts of their presentation. And oftentimes will have their first of 4 IPL sessions or IRPL treatments at the same time. Another thing that's very important, a lot of times patients will ask you, well, how long will this benefit? How long can I expect this to be of benefit? And I always tell them that it depends on the number of oil glands that are open. It depends on how diligent they are with their lid hygiene, warm compresses, anti-inflammatory therapy. And it also varies with the extent of gland loss and atrophy. Those patients on meibography who have extensive meibomian gland dropout, atrophy, and the like should be informed to expect that they may not have as robust a response to the treatment, as well as they may not have as lasting a duration of benefit of the treatment accordingly. Lastly, I would say that it's important to let the patients know when they're having a specific treatment that they are likely to require it again at some point, whether it's 6 months, whether it's a year, what have you. I like to use a dental analogy where patients don't get their teeth cleaned one time. There's no one and done in that. And so some people need to get their teeth cleaned once or twice a year. Some people, need to do it every 3 or 4 times a year. And so setting expectations is extremely important with any office interventional treatment that you're going to offer patients.
Very well put. I would only add to that. The dental analogy is my favorite one for this. When patients say, doctor, after I get this done, especially because it's self-paid, am I ever going to need it again? And I turn to them and say, it's like asking your dentist, am I ever going to need dental cleaning again? This is just like the teeth, and also that brings home the idea of between the treatments we do for you in the office, you don't go home and do nothing. You don't go home from your dental visits and not brush and floss every night. So there is home maintenance and office procedures, they're synergistic. One doesn't replace the other. So patient education, using analogies to bring it home, also being realistic to the patient that this is a maintenance. And also I say, our dental colleagues, like the dentists in the field of dentistry, have done an amazingly wonderful job in educating the public. We never question that, what we have to do for our teeth. We do them at home, we go and see them, right? And I say to my patients that your eyelids, and it's not a biased opinion, I feel like if they're not as important, they're more important than your teeth, because a tooth can be replaced, a lost gland at this point cannot. So you really need to educate your patients, because, I get these treatments done on myself. My husband gets it done in my office, my staff. So we really need to let them know that those of us who are in the field take care of our lids, and they need to do the same until there is more public awareness. So I'm going to have Dr. Kaur express Jane's glance, but at that time we don't have to wait. We're a little bit behind the schedule. I would ask everyone to take a 15-minute break. There is coffee, tea, and they're gonna hand out, my staff, if they haven't already, hand out some specialty cookies. This is the old culture in me that, you know, we need to treat you to some special sweets. So they're coming your way, and enjoy them with coffee and tea. I hope you have enjoyed the program so far. We have 3 more treatments to go, and then we have our amazing speaker, Dr. McDonald, joining us, and then we'll join everyone on the panel and we'll answer your questions. So please enjoy your break. Can we get everyone's attention, please? We need everyone to take their seats. We're getting very behind the schedule, and we need to start the next patient treatment. Also, Dr. McDonald will only be here from 4 to 4:50, so we cannot delay that talk. So we are in a time crunch. Please take your seats. We're going to what I call my gold standard in my practice, the LipiFlow. We're going to have our beloved patient, Ms. Cheryl Jennings. So let's talk about LipiFlow and why I feel like it's the gold standard in my office. As everyone who knows me, I don't do infomercials. I only say what I believe in. So basically, to get the bad out, you need to have a few different elements. You need to have the right temperature, 42.5 degrees centigrade. You need to have the ability to functionally loosen up and get the glands emptied. And the reason I like LipiFlow is that because the heating is done externally and internally, because the eyelid goes into the sleeve. And then once the appropriate temperature has been achieved, then the compression of the glands starts the contraction with the machine. So I'm going to start applying the applicators to Cheryl's eyes, and then we can talk about the treatment as she's sitting there and enjoying this. This to me is truly like a spa treatment. But to begin with, you have to educate your patients, because it's not every day that you get something in your eye. So if it's the patient's first treatment, you want to tell them that it's going to be wonderful once it's in, but getting something inside your eye may feel weird to you. So you just prepare your patients so that they have the right expectations. And then because there is only one size activator and people have different size eyes, you know, I believe that, you know, she has the perfect size eyes for this, but there are patients that this is actually too big with, and that's when I go to other things in my toolbox. But, and if the eyes are too big and the lids are too lax, you may have to do extra taping. It's very important that it activator stays on the eye properly, and the lids are fitting into the sleeves properly for you to get the optimum treatment. Also, after I put the activators in, I ask the patient to gently close their eyes as if they're sleeping. So, another trick to ease it into the eyes that are not as large is to go supranasally first. So you ask the patient to please look down, you take the activator, and you make sure that you have applied Alkane and Propelkane, which my assistant has here, and you insert the upper portion of the activator first, and then gently pull down. And, you know, sometimes you have to pull down harder than others. As I said, she has the perfect eye for this, so I don't have to torture her too much. But the different size eyes, you have to learn and get more comfortable. There are special tape, but you don't really need to have the special tape. You can actually use any tape that you wish. And it's important that you tape all these correctly so that the activator doesn't move as the patient is going through the treatment. Look down, please, Cheryl. For the smaller eyes, when you have to pull harder, please be cognizant that the patient is sensitive, so just be gentle. If you have an assistant in the room, they can hand you the tapes, which usually is the case in our clinic. But if you don't, just prepare everything beforehand. As soon as the activators are in, we start the treatment. And I'm going to ask Cheryl to gently close her eyes. Then I start explaining to the patient what they're about to experience. It's 12 minutes of a nice warm spot treatment for your lids. And basically, the activators start doing their thing. I like to tell patients that, as you can see, your eyes and eyelids are getting warmed up, and you're going to go through cycles of contraction to empty the glands. Are you comfortable, Cheryl? When it comes to choice of which tool to use, all of us, just like cataract surgeons, we don't use the same IOL for every patient. We look at the parameters, what the patient's requirements are. Each, there is no cookie cutter treatment that should be applied to any patient with any disease. As I said, you need different tools in your toolbox, and you need to use them appropriately. If the glands are basically clogged up with very hard material, I need to warm up the glands before applying these. So I do use TearCare before I do LipiFlow. And I would even follow that by doing manual expressions. So there are severe cases that need all that. I've had severe cases where the patient comes to my office and says, I got LipiFlow done in so-and-so's office and it didn't work. It's because they're so hard that you need to do more than that to empty it, at least for the first time. But once you do the emptying of the gland the first time, your job gets a little bit easier as you go. As I said, emptying, getting rid of the bad for the good to come in also requires you to induce the good to be formed. So that's when I package these with the IPLs of the world and other treatments according to the patient's disease. So this is a multifactorial disease, and you have to approach it with multifactorial treatment plans. And if you get a patient in your office just because you bought one technology and just do that and say, okay, I'll see you next year, I promise you, you lose the patient, because the patient is going to go home and say, I just wasted my money, nothing worked. Well, our knowledge has to be so solid in the field. And as the doctors, we have to come up with specific plans for each given patient so that they get the results they need, and then they'll come back to you and they'll send their friends to you. So I know some of you came to me during the break and told me just talking about these pearls in our practices is important. You guys now, I'm very gracious. I mean, I'm very grateful to your gracious comment. One of our audience optometrists came to me and said, now I know how to have the dialogue with my patients. And that is exactly what we're here for. That's what I mean when I say doctors need to teach doctors. I don't think this teaching should come from industry. We are thankful for the industry having the technology, but we learn from our colleagues. So we need to put them back in charge. We need to make this a subspecialty, and we need to train the next generation of doctors. As I said in one of my videos for the invites, before those of us who are in the field retire, we need to have patients. I'm going to make a selfish statement. We need to have them take care of our eyes. Who's going to take care of my eyes? So, we do need to train more doctors, and that has to be an organized fellowship. Technology is advancing. We get so much more every single year, and it's getting complex enough that it does warrant a year fellowship in this field before people are confident in having these dialogues with the patients and bringing the awareness to dry eye disease that's needed in the field. You're doing good, sweetheart? Okay. It's also important to know that when you're doing these treatments, sometimes a patient could be claustrophobic. I have patients who have asked me, can you do one eye at a time? And I always oblige them. I know we're busy in the offices and time's of the essence, but you need to cater to your patients. Also, sometimes patients it's uneasy not to be able to, it's not easy to not see anything and kind of be left in a room. So I often, if I'm not able to stay in the room, one of my technicians will stay in the room with the patient. and, check on them and make sure that everything is good. Also, that's important because sometimes if you have a very large fissure and the lids are loose, the activators can come out during the treatment. So you need to be there to attend to that so that you don't waste the treatment. Earlier in my talk, I said that our estimates of dry eye disease is an underestimation. And the reason I say that is because most people who have dry eyes, it's silent in them. So they don't know they have it. They don't seek treatment. But they don't go to the doctor's offices. Now, even when they do go to the doctor's offices, a lot of the offices in US and elsewhere are lacking diagnostic tools to appropriately diagnose this disease. And even if they have the tools, in any given office, in my own office, us doctors are different. We don't use all the technologies that are there consistently the same way. I may want, if I'm in the office, I may ask for a LipiView and, diagnostic testing beforehand on every patient. Another doctor in my office may not do that. In my opinion, a true, complete eye exam should start from the lids. If you haven't looked at the lids, don't bother looking at the eye. You're behind the 8 ball. It's like going to a primary care physician. They haven't taken the blood pressure. They haven't listened to your heart rate. And now they're going and investigating your heart. It's just backwards to me. So when a patient comes into your offices, just make it part of your routine. It may sound like a lot of work, but it's not. It really, once you're used to it, when I get in the office, as my staff can testify, my patients, I get the LipiView, that gives me the structure. So the patient and myself, and I believe patient education is at the heart of everything here. When you show the patient the glands, the picture speaks 1,000 words. So, they see it, they hear it, they know there is a problem. Then in the room, when the patient is at the slit lamp, everything I do, starting from the lids, I'm pressing on every single lid. And I'm looking at what's coming out, the quality of the gland, how hard it is or how easy it is to get the oil out. And I have a video camera, a live video camera, and the page is getting recorded for the patient. So once I'm done with the examination, as I'm talking to the patient, what I'm observing, the patient goes away from the slit lamp, the video goes on, and the patient observes everything that I told them. And I repeat what I just told them. So the education is getting done every second of my examination. I have the same, I have technologies for the back of the eyes. Once I enter the room, I'm showing them everything I see in their eyes. So I believe with the amount of technologies that exist, we have all the tools to do it right by the patients. I believe to respect our patients is to educate them. We need to talk to them. We need to show them what's going on, and then respect them with the choices they're going to make from there on. I know some people have asked me, these are not insurance covered procedures, and it's hard for people. I struggled with that myself. I'm not a salesperson. I don't plan to be one, but I struggled with the ethical issues of what do I do? On one hand, they have a disease and the treatment is not covered by insurance. So do I tell them or do I not? I decided as a doctor, I need to tell them. It's their right to know that there is something going on. We heard from Kate earlier on that, she said because it wasn't diagnosed, even though when she goes back to her charts, it was all over the charts that she has dry eyes. Because it wasn't diagnosed, it wasn't communicated, it wasn't treated, she's now, as a young professional mom, is dealing with a debilitating disease. So ethically, it's our obligation to investigate, to tell the patients what's going on. And then it's not our job to apologize for the insurance companies. That is a huge problem here and elsewhere in the world. But that is not my job is to educate my patients, give them treatment options, and just leave it at that. There is no pressure to get treatments. Once they know, my job is done. Now it's on their lap, and I've done my ethical obligation, and I can sleep easy at night. I don't know, as I'm doing the treatment here and you're almost done with this station, it would have been nice if I could have had, questions from the audience, but I'm trying to share with you guys everything that I've dealt with in the past 25 years of practicing in this field. You're good? I think Cheryl can even mention some of the things that, we've gone through all these discussions, right, Cheryl?
You are a great teacher, and I appreciate the education because it did help me inform my choices. And some is covered by insurance and others aren't, but you gave me enough education that I could make good choices for what I could afford. And when I could, then I did this. This is so helpful to me. But I have to do everything else with it too.
So on that note, our effort in our practice to cater to everyone. My patients come from different walks of life. One of my offices is in a very poor neighborhood where they need a lot of care. And it is our job to be doctors to all, not just the rich and the famous. So towards that end, we put different packages together. If they cannot get LipiFlow done, I do manual expressions. I do heating compresses in the office. I do whatever I can. One of my patents is a device that hopefully will be more affordable for them. I would love to leave a legacy and treat more people in the world. I would love to be part of a formal educational forum, a subspecialty to treat more, to teach more the younger generation, to teach them to treat this disease seriously for those of us who will be older by then and those of others that don't have access to us. I made this event available on Zoom so that globally doctors can see what's getting done and so that the education goes further. There are things that are dear to my heart. That's educating our amazing next generation and educating them well. It is to treat our patients. Our patients are first, second, and last. When we make it patient-centered and heart-centered, things work out. We just have to think outside the box and make it work for each individual patient. We're going to go to the next station because I think you're getting tired of my voice now.
All right, are we going into the Eastwind? or-
We're going to this one, but do you want to share any, as they're getting the patient ready, do you want to share any pearls in
Yeah.
your practice?
Oh, sure. So I've enjoyed using the Eastwind IPL machine for my patients. I've used various intense pulse light machines, and what I find for a lot of the patients that have rosacea, dry eyes, they're receptive
a lot
to
too,
treatments
thank
that are not painful, that work well. And what I really like about the Eastwind technology is that it's in a more compact type of device. I can travel with it. We can have it in our satellite offices. It doesn't take up much space and it's very easy to use. I've kind of described it as like the Apple products of intense pulse light machines because it's a few clicks of the button. You don't have to pick out settings. It's a really straightforward for you to use as a physician treating the patient. And for the patient, it's very painless, quick, easy. I can treat for dry eyes underneath the eyes. I treat in the infraorbital area. For those patients, I'll basically do a double pass with the IPL. Very quick, easy to tolerate, same day procedure, go home, no activity restrictions, easy recovery. I sometimes have patients that come in with chalazion. And so we offer a package where I can basically treat around the chalazion with the IPL device to be able to shrink down, some of the inflammation there. So it's been a very useful device for those patients as well. And I also use it for aesthetics in my practice, and I do a full face treatment for some of our dry eye patients because there is that overlap in the aesthetics world. Many of the dry eye patients will just opt to have a full face treatment since they're already having it for dry eyes. So I really enjoyed the device in our practice, and it's made a lot of sense for us and our patients.
Mic back on, thank you. To take out the activators, I find it easiest when you take the lower end of the activator out first. So it kind of slides out. So you basically pull down on the lower lid and you gently lift the activator over the lower lid and take it out. again, she has the perfect size eye, but in the smaller eyes, that helps a lot so that you don't abrade the cornea. We're gonna go to the next treatment.
So we're just treating in the infraorbital area, making passes that slightly overlap. And we're also looking at the skin after the treatments and seeing just a little tinge of light pink is acceptable. In our male patients that have maybe darker facial hair, always important to have them, shave beforehand because any intense pulse light machine is going to absorb into heat. So just these considerations to think of with different patients, but he's tolerating it very nicely. How does it feel?
I can barely feel it.
He's a great patient too.
Oh, yeah, absolutely. And so that's it. It's just a very quick, simple treatment.
Good afternoon, everybody. So first step, yeah, he put in some anesthetic drops. So the MGRX does 3 treatments. If you want to go ahead, this is thermal debridement. So 3 different instruments that plug into one handheld device. So this is thermal debridement that we invented. He's just doing a light pass on those lid margins. That's just to decap the glands, remove that biofilm, get it ready to be heated up and expressed. So this step takes a minute or so. He's already done. Second step is thermal massage. So you're probably familiar with that. The instrument has a concave tip that's heated to 44°C, a little bit of ultrasound gel on there to reduce friction, help with heat transfer. And this treatment's going to be about 1 minute per lid. Actually, it's blinking, so it won't. Just go ahead. So it's got a built-in 2-minute timer. So he's going to do about 1 minute per lid. And of course, the idea here is we're going to liquefy that meibum such that we can easily express it. This device over here is a preheater, and that's part of the system. And the only reason that we have a preheater is to heat up the instruments so that they are close to temperature so that we can save your time and save battery on the device. So I'm going to go ahead and load the expressor for him. So this is the thermal expressor. And we've done a couple things here. So heat is only being transmitted through the red paddle, which is the external paddle. So external to the eyelid. And we've also reduced the pressure such that you cannot put more than about 12 PSI on that eyelid. So if anyone's had a regular expression with a metal expressor, I see some heads nodding in here. How many people have a metal expressor in their drawer in their practice? Everybody's got one. How many people use it on a regular basis? Very few, right? Because it hurts. I've had it done. So with the heat and with that limited pressure and with the 2 heat treatments we're doing previously, we're keeping heat on that instrument. I do not have tissue. Aha. Tissue for the patient. We got to wipe off that ultrasound gel. So the thermal, so he's already done with the massage. And next step is that thermal expression. This is going to take 1 to 2 minutes. You're just going to, and you can also see that the expressor is angled such that, go ahead and use it now. I'll get another one. You can see that it's angled for both upper. I think he's going to start on lower lid expression. So you can see the angle here. Go ahead and pull that lid back. And again, he put some proparacaine drops in prior to the expression, but not a whole lot of pressure. So should be very comfortable for the patient. We'll ask her. I think she said, yep.
As they're finishing up here, we would like to give a break before we start the Q&A session. And please use the bathrooms. There are extra cookies if you enjoyed them, please help yourself. And we're gonna, sharp at 4, we have to take our seats because Dr. Margaret McDonald will be the first speaker and then Q&A after that. And we're happy to answer all your questions. One thing that I haven't seen people take advantage of are we have a professional photographer here. There's a beautiful backdrop. All your families want to know where you're at. So take advantage of it. Take your own take photos, get them professionally done. I'll share them with the group. So please take advantage of everything that has been provided here. Enjoy your day. Learning should be fun. So have some fun with it. We'll see everyone seated in their seats at 4 o'clock because Dr. McDonald is on a tight schedule. Thank you so much.
Thank you. I did want to mention one more thing while he's finishing up here. We do also have a 4K camera system that would allow you to record and take pictures of the treatment while you're doing it. And we actually can control that with a foot pedal. So very, very easy to do that. That camera right there, yeah. And that is magnified 3.5. So you can get really close up with that. I wanted to, can we ask you how that treatment was?
It was comfortable. There was no pain.
Okay. Can we call it a spa-like experience?
Yes.
Excellent. Thank you very much.
We're starting the Q&A session. Dr. McDonald is going to start her talk soon. Please, everyone, if you would please take your seats. We're going to start the next session.
I'd like to go ahead and introduce Dr. Marguerite McDonald. I'm going to kind of read what's here, but I have so much to say about her. So she's a prominent figure in the field of ophthalmology. Her career has been marked by significant achievements, including tenure at LSU Medical School, where she became a full professor of ophthalmology, director of the corneal service, and chairman of promotions and tenure. In 1994, she established the Southern Vision Institute in New Orleans and later joined Ophthalmic Consultants of Long Island in New York in 2006. If you will remember, there was a horrible, horrible hurricane that happened in New Orleans. So that's how she got to New York. She's a staff physician at several esteemed medical facilities and has been actively engaged in groundbreaking research, serving as a principal investigator on multiple NEI R01 research grants. Dr. McDonald's pioneering work in refractive surgery has led to the development of innovative procedures and earned her numerous accolades and awards, including induction into the ASCRS Hall of Fame and the 2023 ACOS Visionary Award. With a vast body of work encompassing over 1,800 publications and a number of patents in the field of cornea and refractive surgery, Dr. McDonald's influence is felt far and wide in the medical community. Her contributions to the field of ophthalmology and her dedication to the well-being of others is truly commendable. She is truly a visionary, a representative of women in ophthalmology, if you will. And didn't you do first LASIK? First laser vision correction in the world was done by this woman. She is a wow, right? And she's here today to speak to you. Aren't you lucky? Here you go. Sorry.
Thank you, Patty. I can't believe this venue. With the stunning views, I don't know how any of you will ever look at the slides. Here we go. right there. Got it. Thank you. So I'm going to talk about dry eye and the pre-op cataract and LASIK patient. And here are my disclosures. I do not consult for nor own stock in a company that provides tear osmolarity testing. So we know the ocular surface is a key component for surgical success. OSD, dry eye, and MGD are present in the majority of our cataract patients, and many of our LVC patients, they select themselves out of the population because they're having trouble with their contacts due to ocular surface disease. We know OSD reduces the accuracy of all pre-op refractive measurements, and it reduces visual quality and quantity pre and post-op. And this is rough because expectations are higher than they have ever been with our surgical patients. It's been proven that cataract and laser vision correction will worsen OSD, and that MGD, blepharitis, may increase the risk of endophthalmitis or TAS. So, besides the basics, the modern LASIK cataract workup should include a questionnaire. I use the speed questionnaire. In the first visit, it gives me valuable information and it shortens the visit. And topography, do it early before the manifest refraction or the IOP, and it reveals dry eye and other subclinical irregularities. I also rely on tear osmolarity, which has been validated many times in the peer-reviewed literature. So for these pre-op workups, I tell the techs to stop and show me the chart instead of going on to dilate and OCT the macula and all of that. Show me the chart if there's a history of complaints consistent with OSD on the questionnaire, the patient has a pre-existing history of OSD, the topography shows distortion or dropout, or the tear osmolarity is elevated, greater than or equal to 317 milliosmoles per liter. If it's between 296 and 316, I say to them to proceed with the remainder of the workup, but initiate treatment before a surgery. So why stop? Just a little more about this. There is enough evidence in those few bullet points of significant OSD for the surgeon to do the slit lamp now before the manifest refraction biometry dilation, halt the exam, introduce yourself, meet and greet, explain the situation, initiate treatment for 2 to 4 weeks before the patient returns for the workup. You will not lose the patient. I've been doing this a while. I've never lost one. They are grateful that you are careful. So don't book the pre-op and surgery in the same week for someone you haven't met. And really, if some of your patients come from a long distance to see you, the appointment staff has to warn the patient that the first visit, this is automatically advancing, that the first visit, depending on what the surgeon finds, might not be the only pre-op visit. There might be a second pre-op visit necessary. Now, if the patient was sent by a referring MD or OD and there is significant OSD that requires treatment, you have to handle this carefully. Be honest, but consider the referring doctor. There are so many peer-reviewed publications now proving that an optimized tear film helps with outcomes. This is a little snapshot courtesy of my partner, Eric Donefeld. It shows a topography before treatment with cyclosporin and after, and what an enormous difference. This is from Ken Beckman. This is before wavefront guided LASIK. On the left, you see the patient had 3 diopters of irregular astigmatism, and after only 2 weeks of treatment on the right, it drops to a half diopter and it's regular. So I use tear osmolarity as the basis of a dry eye treatment algorithm. As I said, it's based on peer-reviewed publications and years of personal experience and data collection of my own. It's totally in line with DEWS 2 and the ASCRS guidelines, and it has been unchanged for the last several years. It provides a clear-cut guideline for initiating treatment and tracking the response to treatment. So I start treatment at 300 milliosmoles per liter or higher. And at this level, it's just unpreserved tears, QID, and omega-3s by mouth. At 317, I add cyclosporin or lifitegrast and varenicline nasal spray if needed. At 325, In addition to the tears, which are preservative-free 4 to 8 times a day, I add a bland ointment at night and I use plugs, usually 4. And I do this only if the MGD is under control. More about that in a minute. Sometimes I add at 325 or higher preservative-free amniotic membrane drops, QID. So many papers proving that lifitegrast and cyclosporin work to treat dry eye. So how about omega-3s? There's peer-reviewed literature to support this as well. This is just one of the classic studies from Epitropoulos showing omega-3 treatment versus the control had a significant decrease in tear film osmolarity as early as 6 weeks, maintained at 12 weeks, and the OSDI scores, the happiness questionnaire showed patients were much happier on omega-3s. At 3:30, I order a blood test for Sjogren's syndrome. At 3:35, I consider an amniotic membrane for 5 to 7 days, usually one eye at a time because that blurs them terribly. And I delay surgery until all filaments are gone. You don't want to operate on an eye that looks like this. You are headed for trouble. Your pre-op measurements will be nonsensical. They will have a rough recovery. It's just a disaster waiting to happen. Now, a little sidebar here. Chronic dry eye can cause stage 1 neurotrophic keratitis. So if you see stain without pain, and stage 1 is just ratty epithelium, and under normal circumstances, the patient would be really uncomfortable, but they're not. So if you test them, and it only takes a moment with a cotton Q-tip, if you document they have reduced or missing sensation, oxervate, Senogermin, which is DNA recombinant nerve growth factor, 6 times a day for 2 months makes an enormous difference. So as 86 to 92% of dry eye patients have an evaporative component caused by MGD, I very quickly use an MGD grading system to add treatments to the osmolarity-based dry eye algorithm. And those, once again, this closely mirrors the MGD workshop recommendations. Just to refer to a truly classic paper from Mark Speaker in Ophthalmology 1991, endophthalmitis prophylaxis. He proved that an organism isolated from the vitreous in endophthalmitis patients was genetically indistinguishable from an isolate recovered from the patient's eyelid, conjunctiva, or nose in 82% of the cases. So treating MGD actually is endophthalmitis prophylaxis as well. So I quickly grade. This is between a 1 and a 2. This is a 2. This is a 3. And this is grade 4 with neovascularization of the lid margin, pouting glands, an opaque meibum as opposed to a nice clear meibum. And the orifices have started to actually migrate forward. Now, meibography, it's very useful in making a decision about treatment. But more than that, I think it's more helpful as a patient education tool. A picture is worth 1,000 words. You say, you know, your glands should look like the top here, but instead yours look like the bottom image. It's like a brick in the face. They understand, they have a real problem. It's not imaginary, and they will listen to you regarding any treatment recommendations. Now, another sidebar about Demodex blepharitis. So if you see collarettes to the far left, grade 4, all the way down to grade 0, collarettes are absolutely pathognomonic for the presence of Demodex mites. And if they get lotilaner, XDEMVY, twice a day for 6 weeks, it is incredibly powerful and effective, and they will go to grade 1 or grade 0. So grading MGD at the slit lamp, stage 1 or less, very mild. I just observed the patient's already on omega-3s. Stage 2, mild to moderate MGD, I add the soaks and scrubs twice a day, and I switch bland ointment to erythromycin or bacitracin ointment. And lately I've been adding perfluorohexyloctane MIBO drops 4 times a day, OU, which is specifically for evaporative dry eye, highly effective, easily tolerated. I encourage microblepharoexfoliation and thermal pulsation therapy pre-op and at least once a year. And IPL is also very useful. We don't have one in our practice. We have BlephX and LipiFlow, but IPL, there's a huge body of published literature. It gets the same job done. It's also very useful for this. At stage 3, moderate to severe, they're on all the prior recommendations. And anybody who's had a recent chalazion gets doxycycline 50 milligrams PO QD for at least a month before surgery. Warn them about pregnancy, warn them that they will be very photosensitive. Tell them not to take it on an empty stomach, but not within plus or minus 1 hour of a meal containing dairy, because that will inactivate it. So for stage 4, this is in addition to all the previous therapies, microblepharoexfoliation and thermal pulsation treatments are basically required pre-op. It's not a choice anymore. And post-op, to maintain their healthy tear film and their good optics, they should undergo microblepharoexfoliation at least twice a year and thermal pulsation therapy once a year. So this sounds like a lot. It's really, after the first day you do it, it's locked in to the hard drive. You don't even have to think about it really. And it takes only a few seconds to grade their dry eye and their MGD. So in summary, dry eye must be managed in the surgical patient to enhance outcomes. Tear osmolarity is used as a primary element in this OSD algorithm, and it determines dry eye severity level and guides treatment. And since most dry eye patients also have MGD, the treatments for lid disease are added as needed. So this treatment algorithm is not unique to me. It very closely follows the recommendations of DEWS-2 and the MGD workshops. In other words, its foundation is science-based medicine. Thank you.
Going to go to Q&A, and we're going to have the audience ask their questions from Dr. McDonald first, as she's on a tight schedule and has other commitments. So Dr. McDonald, if you would like to take the first seat, Patty just emptied the seat for you. So any questions for Dr. Marguerite McDonald? I have one. Yeah, please go ahead.
No microphone.
Can we have all the mics active? Yeah.
Yeah.
Okay. How do you remember all that?
Is this on?
Yes.
Like I said, the first day you have to have it taped to the wall. So you examine the patient, you go, and then literally by day 2, you've got it
Good.
memorized.
Hopefully.
Yes.
I've known Dr. McDonald for a long time. I have so much respect for her. And we were on some advisory boards together, and we were Inspire Days. We had some, so tell me, all of these audience always wonders, how do they do it in a busy practice? You said that it can be faster, but once you told me your conversation about dry eyes should be about 30 seconds, no more. And you gave this beautiful 30-second of, what you say to your patients. Can you share that with us?
So I'm in a practice that's owned by private equity, and every day totally different technicians show up, because we have like 75 offices, and people show up who have no idea that I treat dry eye or what I do. So I've had to memorize my own little speech, and I give it. I can't say, oh, Marianne will tell you about this, So I say, you have dry eye, it's significant. Everybody gets drier with the passage of time, especially women due to hormonal changes, and you're on some medicines that make you drier. So in addition to your complaints, what I see at the slit lamp and the tear osmolarity score, the saltiness of your tears, we need to put you on a prescription medication. So this is either, Xiidra, Lifitegrast, cyclosporin. I say, you're going to take it twice a day, and it'll help you make more tears and higher quality tears. And then I do a quick little sidebar. If it's Xiidra, I explain they might have the bad taste. They might have burning on installation when they first started, but nothing's wrong. Brush your teeth, use mouthwash, chew a piece of sugar-free gum for the Xiidra. If they find burning on installation, and this goes for cyclosporin, put it in the refrigerator or even the freezer and it'll feel fine. And then I just add the other treatments, and it really doesn't take that long. But if you can't stand it, if you can't stand doing this, and you can't stand unhappy middle-aged women, of which there are a lot, if you do dry eye, then you have to find somebody else in your practice who will. So you have to say, I have detected that you have significant ocular surface disease that's going to interfere with our surgical plans. It'll just take a few weeks to get this treated and under control. And I want Dr. Smith over here to take over. And he will return you to me when your eyes are in tip-top shape. So if you don't do it yourself, somebody else in the practice has to do it. Even so, I hear this all the time. I don't want a dry eye patient in my chair. I want a pre-op cataract patient in my chair. Well, it's the same person, you know? You can't escape it. You have to deal with it. You can't escape it.
There's a question from the audience. Can we give them a mic, please? You stand up and yell. Stand up and yell. Okay. My question, you give the patient a literature or a checklist.
So most people don't need all of them. You know, there are very few people, even in a referral practice, that are level 3 or 4. Most of the time it's level 1 or 2, and it's been undetected by other clinicians. So yeah, we give them a sheet. While I'm explaining, the technician is quickly writing it down. We also have lots of brochures and information to give them. But yeah, so I hit the high points. I will leave the hot soaks and scrubs education to the technician. I'll say, you're going to be doing some lid cleaning twice a day, and I'm going to have Mary Jane explain it to you. That I will do. But if I just say, you have OSD, ocular surface disease, and she's going to tell you all about it, and you don't mention the drugs, you're not specific at all, then the compliance is terrible. But if you say, we can't proceed unless you do this routine, we really can't proceed. You know, you have to be very forceful that way. And you don't lose people, you really don't. They're very grateful.
Have the conversation of coverage or not coverage of the procedures like UPO and IPLs and all that, or just with the patient, and what's your conversation?
I rarely recommend BluffX.
Oh, my.
Was that me? Did I do this? Or did I? Okay, so I rarely recommend BluffX LipiFlow the first time I meet somebody. Sometimes I do if they're severe and they've already seen several other clinicians. But if you meet somebody and you say, hi, you've got this condition you didn't know you had, and by the way, we're recommending a $900 treatment. I mean, you know, you lose the patient. So I put them on a regimen and I have them come back. And if they're not pre-op for surgery, I talk to them. If they're improved but not perfect, improved but still somewhat unhappy, or they can't stand doing all of this, they absolutely can't stand it, then their mind is open. The conversation about BluffX LipiFlow goes very well at that point. So, okay. So if you do this in-office procedure, which is not covered by insurance, most people fill out a care credit form. It's not, you know, and they pay a little bit each month with no interest for 2 years. But if you decide to do this, and I tell them the truth that we pay the same thing as the patients when we get it done, which is true. Thank you, private equity. But I say, you know, the reason to do such an expensive treatment is the average person gets to jettison 75% of the routine that you're on. Less time in the drugstore, less time in the bathroom. And it's been shown to be more effective than scrubbing and erythromycin ointment and all of the things that I've put you on.
And you do have to be careful with people that you recommend cash procedures to
yeah.
prior to surgery that's covered by CMS, because you can't say you can't have the surgery until you have this. and expect them to pay out. They can, you know, that can create an issue. So it has to be
Have
an
to be,
elective
yes.
component, education and elective on the patient's part.
Exactly. Yeah.
Yes.
Would you consider using a low dose of steroid in combination of to cyclosporine for treating dry eye?
So steroid injection,
Or low dose, you said injection?
induction. Oh, you
Oh.
mean to
Induction.
add the eye drops,
Mhm.
steroid drops?
Like Lotemax, BID or something?
Yes, that can be very helpful. I have found that with the newer formulations that they don't really need it, like Cequa. I have found that steroid induction along with cyclosporin is rarely needed. But if there's a time frame, if somebody needs to have surgery before they go to Europe, you know, for a year, or, you know, there is a time frame involved here, then I will use steroid induction. But otherwise, you know, Cequa and Xiidra both start to kick in significantly as early as 2 weeks.
Yes, I so appreciate your time.
Thank you.
Thank you for being here. I'm gonna say goodbye to her. Please continue your questions with the panel.
All right.
Don't be bashful, people. Come on. Anything's on available for us to chat about.
As most likely known to all of you, as U.S. Preventive Task Force for Primary Care requires that we screen most adults over 19 years old with depression and anxiety. And we use a very simple form called PHQ-9, which includes 9 questions, which very accurately, believe it or not, screens if you're depressed or anxious. And then we score. Well, actually, the anxiety is a little different questionnaire. When it comes to screening my patients for vision and difficulty, all we ask is, are you having any difficulty with your vision? And that's usually no.
Yes.
So I was wondering if your academy would make such a questionnaire that would kind of triage by asking few questions. As you know, I know one thing that stuck in my mind from medical school years is that one of the symptoms of a dry eye is feeling like sand is in your eye. No? So I was wondering if the academy would come up with such a questionnaire that I can add to my history taking regime to see if I can then send, to kind of discern how serious the dry eye is. Of course, it very much correlates with age, everything, huh? As your skin becomes more dry, I'm assuming that your eyes become more dry as you age. And of course, polypharmacy makes it even worse. So I wonder if the academy is going to come up with such a question that can quickly tell me that, is this just a dry eye or is it dry eye disease, as in DED that you talk about, that requires more intervention and referral to an ophthalmologist?
I'll start out with, I think the speed questionnaire that we use is a tool that attempts to quantify the symptom severity as well as symptom frequency. And it helps to kind of draw attention with the questions within the speed questionnaire that's readily available. I'm sure it can be downloaded and the like, that asks specific questions that point to dry eyes, such as fluctuating vision, foreign body awareness, burning, tearing, dry eye awareness. All these are questions that provoke the patient to reflect on whether or not, these really exist, because dry eye means different things to different people. There are a lot of patients that'll come in and say, well, my eyes aren't dry, but then you ask pointed questions and it's very evident that they have dry. And, you know, especially with ocular fatigue. I mean, it's a vague symptom, but is very sensitive to.
I think, yeah, I think one of the testimonial patients today spoke to the fact that early on for her, you know, her symptoms were different, right? And she didn't, over a period of time, it worsened. So, you know, if you use the SPEED, which is the Standard Patient Evaluation of Eye Dryness, which was originated by Tier Science, now J&J, and our practice has taken that and modified it to add little boxes to alert us for allergy testing or Sjogren's testing. It's just driven trigger points, if you will. But any patient with a score of 1 in our practice is considered to have a sign or a symptom of dry eye. You know, the patients that take the longest for the providers are the patients that are asymptomatic. The asymptomatic patients are the hardest patients to take care of because they're like your glaucoma patients. I feel fine. I don't have any vision loss. I don't know what you're talking about, you know, and when that all starts to happen, it's too late. Same thing with the dry eye patient.
To your point, I always emphasize to my staff, you don't find problems you don't look for. And having a questionnaire for patients, regardless of their presenting problem, helps us to identify these patients early.
And it's also used in the progress, if you will. If you do a SPEED score on every visit, a patient may have gone through a treatment, been on meds, may come in and say, I'm not sure. Then you can see your SPEED score improved. Just that particular metric right there alone is a metric. And you can watch, if you create flow sheets, you can watch those metrics change and the speeds change. And you know the patient's either dropped off at home, they're not using their meds, or something's happening.
And it also helps to persuade the patients that they need a subsequent interval treatment, MGD treatment, say 6 months, a year later. You know, they come back and their speed scores increase, their lipid layer thickness is diminished, their number of expressible glands is diminished from what it was a year ago. Then it's an easier conversation to persuade them to entertain another procedure that they had before.
I think in the primary care office too, you know, to think about the patients, this might be more relevant towards the patients that have rheumatoid arthritis, these autoimmune conditions. We don't see those patients unless they're on Plaquenil or something in that way. And then we're asking them about dry eye disease. But I think for a lot of those patients, the diabetic patients, the menopausal patients, to kind of target the questionnaire even towards them, because it might be more time consuming to screen everybody, you know, for dry eyes. Those would be the top 3 groups. I would say it would be so important to get them to the eye doctor earlier, even, you know, outside of the diabetic eye exams and the Plaquenil use that we would normally see them for. I think they would appreciate that too. And patients that are on a lot of these blood pressure medicines, these things that can dehydrate. Yeah, I mean, make a big difference.
Yeah, it's just, you know, if you select groups of individuals to target, you're leaving out a whole subsection of people that are starting with dry eye disease that you can catch. They might not be back in your office for 5 years, and then it might be too late. So that's why we use a SPEED on everyone, unless it's an emergency, because it's going to trigger wrong answers or immediate post-op. Otherwise, everybody gets a SPEED.
Another thing in a primary care office is you're in a position to be monitoring their systemic medical therapy. So if they're on anticholinergics, antihistamines, diuretics, and the like, then just having that heightened awareness to even ask if they're having any dry eye symptoms can be helpful.
Also, often I hear from our colleagues that if my patient has no symptoms, they're not going to listen to me, or I'm not going to talk to someone who doesn't say I have dry eyes. My response to that is that, you know, I don't go to my internist and say I have blood pressure. I don't, you know, there's a lot of diseases. There are a lot of diseases that are asymptomatic. Diabetes gets discovered by my physician, not myself. I don't feel my sugar. I don't feel my blood pressure. I don't feel my hemoglobin. It's my physician who measures it and tells me that there is something wrong. We are the physicians and we are supposed to look. And, you know, to your point, if you don't look, you don't see it. And you are doing your patients a disservice by not looking. So look and have the conversations and then use analogies. Analogies are so wonderful. Just by saying, a patient says, I don't feel my, you know, I often have patients with dry eyes in both eyes, but the eye that's the worst, they don't have any sensation in it. And they're like, oh, that's my better eye. And I'm like, no, it's not. You're just like the diabetic patient who just lost sensitivity in their feet and they don't feel their feet. That's your worst eye. So, lack of signs and lack of symptoms doesn't mean lack of disease. And we're not here just to diagnose diseases that are screaming at us through the patient. We are here to discover the silent ones, inform our patients, and treat them.
I think we here today as use of Accutane and the dryness because you mentioned it also, be careful when you prescribe Accutane and the dryness because in the cornea. And could you say, she was asking me how long does it take for that dryness to go away or how to expect? So what do you have to say? I'm sorry. And also they wanted to know about supplements.
Yeah, so Accutane, I want Dr. Darbandi also to me, I'm sorry, manufacturers of Accutane, I think it's the most awful medication that exists. And I have a hard time bringing my patients back from what Accutane has done to them. Often they're college kids, they're heading to college, mom brings them in, it's an 18-year-old boy or 18-year-old girl, and they're just suffering and they're leaving town because they're going to college. And it's, so how long it takes, sometimes, for most of my Accutane patients, most of them are college kids. You don't even have them long enough to treat them appropriately. So that's the first thing. What are your thoughts on Accutane?
Yeah, I mean, Accutane is a drug that's meant to destroy the sebaceous glands, on the skin to stop this horrible acne. It works extremely well for that. But, we have patients that, were on it, past before, and the demands that are on their eyes, later in life basically make it so that now the damaged, destroyed oil glands, the ones that are left can't compensate for this amount of stress that's on a patient's eyes. So it permanently destroys the oil glands, but they may not realize it till later in life when suddenly, they're getting by, with the amount of oils and tears they're making, but then they, take a job on the computer all day and they can't make enough oils and tears to sustain that. Dr. Bowden presents on a patient, that's who I'm thinking of, the attorney, who I think had a history of Accutane. If you want to elaborate on her case, that was a good example of how it follows them into their later years. For all of us, we're always putting more stress onto our eyes. So I think it's kind of a tough question to answer because while the damage might be done over a brief period of 3 to 6 months, it can be forever.
I'll give you an example. I'll give you a couple of examples. So when we say damage is done, it's permanent damage. So basically the sebaceous glands in the eyelids get destroyed by Accutane, even if they're on it for 3 to 6 months. So the glands that are lost, we have no capabilities of bringing them back quite yet. We're working on it. There are technologies that, claim that they can regenerate some glands, but we're not quite there. So that damage, that loss of gland is permanent, his lifetime.
So
and you're dealing with teenagers.
why don't you think then, as a part of consent, they're told that? I mean, all they basically emphasize on is you are not going to get pregnant. You must sign a contract saying that absolutely will not get pregnant.
As you recall, one of my slides in my talk was all the disciplines need to learn from each other, come have joint meetings. We just don't spend enough time together. We feel like just because we became a specialist, I just care about a pair of eyes in a person. No, I have to care about the whole person. And so do my other colleagues in other specialties. And that's why one of my calls to actions were for all the disciplines to have joint meetings, not just, meetings for eyes and meetings. So I think it's necessary if we're going to be more holistic in treating our patients.
The other thing I would add to that is that whenever medicines are initiated, there's always an assessment of risk and benefit. And when young patients are trying to, reduce their facial blemishes and the like, the benefits of having that treated effectively outweighs the unknown risk of the dry eye and MGD atrophy that can occur. They're not aware of it and their doctors aren't aware of
And
it.
the conversation, when I sit there with mom and dad and my teenage patients, and I tell them, listen, acne is for a short period of time.
but your eyes are forever. The teenagers are emotional, and sometimes, their looks are so important to them, and maybe the dermatologist is getting pressured. But the thing is that then I take that patient, do the gland imaging, show them what's going on, and I'm like, you can't afford to lose these. I can't bring it back. So basically, the conversation has to be with the other treating doctors, with the patients, with their parents, and they're all confused because, to your point, I had just, a parent tell me the other day, why would Dr. So-and-so put my kid on this? And I don't want to get involved in getting anyone in trouble. So it's hard.
Maybe kids that are put on this medication should be referred for follow, just like Plaquenil patients.
Yeah.
Where there is monitoring to take place, like a baseline, and then monitoring to see what's happening. Like you said, the damage doesn't always show up till later, but there should absolutely be warnings.
Is it that certain population, certain kids are more predisposed to develop complications? Like, is there any way, like for any child that's going to go on Accutane recommended by their primary, that you must go, or the dermatologist, go and get screened by an ophthalmologist to see if you're one of those people that are going to have really severe complications of being put on? Oh, that's not possible.
Well, one of the things that we've identified in our practice is the surprising prevalence of rosacea among children. And those are patients that are going to have a predisposition for meibomian gland dysfunction as well. And it can be certainly very challenging to detect it, especially in patients of color, that essentially, you don't see the typical manifestations without slit lamp examination and the like.
You brought up a great point. Thank you for that. The people who have more pigmentation in their skin don't show rosacea as much as a Caucasian type 1, type 2 skin. So I myself have rosacea, and I don't show it as much as my Caucasian patients do. So I have dealt with the scenario where I diagnose the patient with rosacea and they go to their derm and the derm says they don't have it. I want to bring a statistics to people's attention. 50% of people who suffer from rosacea, it gets expressed in the eyes first. So as the ophthalmologist, I can diagnose them and I will diagnose them properly. And, some of them will never develop, skin conditions to warrant treatment, but their eye condition warrants treatment. So we need to kind of like come, and when you said, are some predisposed, we don't know when you put someone on Accutane who's going to lose more glands than others, and it wouldn't be an ethical research study to conduct, because we can't say to people, oh, you take Accutane and see what we'll see. So there are certain things that we can't get the answers easily because there's not an ethical way of doing the research in that.
Another risk factor is contact lens wear. Chronic long-term contact lens wear is associated with progressive meibomian gland dropout and atrophy that we oftentimes will see.
And these
So-
patients are getting contact lenses online, and now they can get an exam online, and it's just a hot mess.
In long-term computer use and the like, with the increased evaporative stress to the surface of the eye that creates an inflammatory environment on the ocular surface. We know that hyperosmolarity, chronic hyperosmolarity of the ocular surface, promotes inflammation. And that inflammatory environment contributes to meibomian gland dysfunction.
Somebody had a question over here. Yeah.
A great question. I like to prescribe it in a lot of my younger patients that are on computers and kind of as a dropless therapy, because a lot of my patients in their 20s, younger, they don't want to use drops. They don't have time to use drops. It's much easier for them to just grab, something like Tyrvaya and use that, quickly. So I have no issue initiating it earlier in the treatment plan for the patient, that it fits their lifestyle better.
As a non-physician, I don't understand why docs don't, if you need a drop, why isn't that offered?
Well,
mean-
from my perspective,
It should be an option.
I don't use it as an initial product, because oftentimes of insurance coverage and cost and the like, that can be a pushback for some patients. I find that if a patient needs artificial tears more frequently than their lifestyle, their work, their temperament allows them to maintain, then that represents an opportunity to introduce Trevaya to supplement or to make it so that instead of every 2 hours, every 3 hours, they may be able to get by with 3 or 4 times a day, along with, artificial tear use with Trevaya.
Like anything that's new, it's gonna take time. It's kind of like in the glaucoma field, when we had latanoprost and then Lumigan came, and it takes time when a product takes its space in that field. So I think Trevaya is one of the newer products. So soon it'll find its space, its proper spacing in our treatment regimen.
Yes.
It's a joke.
I can tell you in Florida, writing a prescription is like making a suggestion.
And maybe
It's-
the pharmacist and the
I have
insurance company.
No
will
idea
agree.
what they're gonna come back with.
Yeah.
I like that. Yeah, I'm gonna use his line with my patients next time. This is what I'm suggesting.
Yeah.
Good luck,
So-
what they're gonna give you.
I can say, from the practice management perspective of it, where you do need to be careful is staff in their attempts to help get something in the hands of the patients. Many times they're coming up with substitutions for the patients on their own, and I think that's a wrong thing. I know we had to put a squash on that. They have to present to the physician what is the substitution you want, because you have pharmacies making suggestions for substitutions and they're not prescribers. And then you'll have the tech going, oh, well, here's the substitution. Yeah, if you can't get that, I guess the pharmacist says it's okay. Let's give them this. And then pretty soon you don't even know what the patient's using when they come into your office. And this goes for glaucoma meds and all kinds of stuff. It's a hot mess.
And it adds to the burden of cost of the practice.
No, there's another question that.
Question is, do you find that patients with treated glaucoma the treatment for the dry eye?
Not only MGD, all kinds of ocular surface is damaged by chemicals. And glaucoma medications and they're chronic medications. They're using them every day for months and years, and unless they have a procedure for the rest of their lives. So definitely glaucoma medications have dry eye implications. Direct damage to meibomian glands, there is evidence of that, but the ocular surface is just unhealthier when they're on glaucoma medications.
We also find that prostaglandin analogs in particular are very damaging to the meibomian glands.
Yes. I actually find it necessary to treat dry eyes when they are glaucoma patients. And I tell them that. My staff hears me say that often, that, they need the dry eyes to be treated because they're glaucoma patients. I had early on in my career, when I had just started my first practice, I had a wonderful older African-American gentleman, just a sweet guy, on 4 different medications, eye drops, and he was in his 70s, I believe. And he came to me, and the surface of the eye, the cornea, was sloughing off. So that becomes glaucoma medication intolerance. And then you're in between a rock and a hard place. The medication that saves their, nerve has to go, and he didn't have much to lose. He had a lot to lose because he only had not much of the nerve left to lose. And I'm sorry. So, and then on the other hand, the cornea is dying because the surface is, has toxicity from medicamentosa that, he's had all these medications. That patient then has to get so much more treatment to get them back to the baseline and have them tolerate their glaucoma medications again, or has to go under, much more extensive glaucoma procedures. I'm sorry.
I was going to say, to add to that, that affects our treatment strategy. There are a number of prevalent studies that show 50% or 50 to 60% of glaucoma patients have dry eye, manifestations of dry eye on the eye. So consequently, when patients present with ocular surface damage, intolerance to the medications and the like, it's incumbent upon us to essentially try to get them on as many preservative-free products as possible and to have a low threshold for MIGS procedures, you know, SLT, canaloplasty, anything, you know, even filtration procedures, Zengel sense. And we do all those things to accommodate these patients. I've actually seen patients come in with red eyes in which the only thing we can do is take them off all of their glaucoma medications, put them on oral carbonic anhydrase inhibitor, you know, Diamox, and topical steroid therapy just to quiet their ocular surface down.
Which is what we did with that gentleman.
Yeah. And then on top of that, a chronic red eye is going to reduce the success of a filtration procedure if they so require.
Yes. Yeah, they don't heal well after their trap surgery if the eyes are. So that's why I was thinking that, you know, when I mentioned that all our other subspecialties, no matter what they do, the surface matters. And that's why I'm asking the academy, why is this not a subspecialty? When everybody, we have more, the disease we're talking about today is much more prevalent than any of those diseases. Some of them all put together don't equate the number of dry eye patients. So why is this not a subspecialty?
Question is now, for wet macular degeneration, do you find that is also a complicating factor?
I do in my practice, and I don't know what my colleagues, so I actually have had, you know, we have multiple wonderful retina groups in town, and I see their patients often. Basically, anytime you have a dry surface with inflammation and you go into it with a needle, you're gonna cause more inflammation. So definitely in my practice, and I don't know how it is in yours.
I oftentimes see with retina referral patients, they have a higher risk of neurotrophic keratopathy as well, due to long ciliary nerve injury or chronic, you know, trauma and the like. That's a real issue.
I think with those patients, you know, back to your original question, it's not more challenging to get the patient to play along, if you will. I think it's more challenging for the provider because so many things are happening at one time, that those particular patients are already conditioned that they have a disease or something going on. And now this is just a side effect of what's going on with that. They're a little bit actually easier because they're used to coming to doctor's appointments. The problem with the doctor's appointments with those, you got a patient in there with a lot of dry eye going on and a glaucoma crisis going on at the same time. It suddenly becomes a very comprehensive exam. So it's not necessarily the patient, it's the doc.
And that takes time.
Slows
to
them down.
Tease out all these contributing factors in their unique ocular surface disease presentation.
I really want to, you know, take a moment to say something about Dry Eye University, if I can, you know. In February, we'll have the 26th Dry Eye University in Atlanta, Georgia. We've had practices from all over the world that have attended Dry Eye University, and it's a little different than this. You know, we do a lot of what we've done today, but it's 12 hours. We spend 12 hours together. It's a Friday afternoon until we start like at 5-ish and we end about 8:39. And then we start up with a full day the next day. It is a lot. But we fill in a lot of those gaps as to the multifactorial effects. What are they? We go over all of them. What are all the meds? What are all the players in the field? Well, how do you start a standard of care? We really do a lot. As you can see, it's complex, but it doesn't have to be complex. I don't think in my lifetime, and I've been in ophthalmology now 40 some years, another new disease process has been introduced with people trying to figure out what to do with it. And it doesn't seem like it should be that hard, but it is really hard to get this and get these patients taken care of. It really is.
I have to say that she does it so well, that if you have a chance, you shouldn't miss it. I've been there and I really have so much respect for how it's done.
Especially after you've done yours.
Exactly. I know how hard it is to, you know, put a meeting like this
and she does so much more. She does, as she said, it's almost a couple of days worth of, so we need awareness. We need awareness in the population, the public. That's why I had some public figures here today. We need awareness in our own colleagues. We need awareness across the board in other specialists to come and join us. So please attend these meetings. It's important for your patients. It's important for your practices.
Another point I would make is that a lot of our practices have a lot of similarities, but they have a lot of differences. And one, I think, positive with our Dry Eye University is that it is a significant amount of time, at Patty's direction, is spent on implementations. And I think when people take a moment to just kind of look at, well, why am I having difficulty implementing this technology or this philosophy in our practice, it helps to identify these contributing factors toward failure. And it may be that you're in a multi-specialty group and you may be a dry eye champion, but your colleagues are undermining you, with shared patients, not reinforcing the messaging that you're giving when they see you. And so there can be a number of factors that lead to a lackluster, dry eye practice.
We encourage, bring your administrator, bring your main clinical person and, yourself, a provider, because no one does it alone. It's a team thing to implement this. And you can go back and we hear all the time, well, my staff doesn't want to do that. That's just too much. Well, that's like the tail wagging the dog, who's in charge, and who's supposed to be taking care of the patients. And you really have to get a handle on that. That's something with your practice if that's happening. But we kind of work through a lot of how to make that happen in the practices.
Another point is you got to be consistent. You got to be consistent yourself as a provider. You have to insist on your staff being consistent in presentation and doing the speed questionnaires and doing the appropriate point of service testing according to your office protocol. And anytime you let up, that's when it fizzles out.
It's like any other disease. I mean, we approach a cataract patient with a great deal of protocol. This is what needs to get done. This is what we need before we decide what kind of lens. This disease is no different. Everything we do takes time. And this deserves the time because it affects everything else. Please.
As a salesperson, I wonder if that trusted advisor salespeople who over time learn to trust because of how they presented their products to earn that. I wonder, what's the best way to get information to you? Is it through your practice administrator? Is it by sending literature in mail? Is it by emailing? Is it by trying to call and ask for an appointment? And then I have a solution thought, which is I see as I go through now a whole country, 11,000 practices, and I look and I see this is our doctors, this is our locations, so and so on. And then it's contact us, and there's a place for the public to ask questions about a procedure or the service. If there was one more icon that said vendor relations, that vendors could go to submit that they would like to share information with the practice. And then at the leisure of the physician or the administrator, or that they could look at something that someone has said, I have this, it just came out today, I'd like to share this knowledge with you. Your point earlier too, about doctors teaching doctors is the ideal, and it's the way to go. But if a new product is invented tomorrow, my point is, how do we in the field, on the vendor side, get that information?
I really think the reps in the dry eye field are behind the 8 ball because the training is not done by doctors and doctors. When someone comes to me with a new IOL, they get my time. They get my attention.
Well,
But
I'm going to differ a little bit.
But what I'm saying is that
if the doctor is not taking the disease seriously, they're not going to look at new products to treat that disease. And they
Yeah.
have to make the disease a serious consideration. And so
I think it depends, everybody should work to the highest level of their education or degree, right? There has to be a trusted person in that practice that says, like in our practice, I brought LipiFlow to our practice. I bring things to our practice. The minute I presented it, it was
but
like,
Patty,
"Oh, yeah."
there aren't many like you.
No, there's one sitting right there. I know they are out there, but you're never going to get anything done in a practice without an administrator's involvement. You can get shut down because an administrator doesn't want to be bothered with something. And that's unfortunate, but there is something to be said with industry has to provide education as well. They have to provide, dinners, luncheons, have KOL speakers that are speaking. There's a lot of different things for physician involvement, but we also need to rely on app specialists that are able to train and teach how to do treatments. You can't trust everyone though. You have salespeople that come in and will tell you all kinds of things that are untrue. And unfortunately, some people believe them. And that's where it's, teaching ethics and teaching honesty and then somebody being there after the sell. It's an important thing.
I think one point that would be helpful from an industry standpoint is, utilizing YouTube, iTube, various media that doctors can access at their convenience outside the clinic hours that can at least get a foothold, can then allow us to approach our administrators and say, we want to consider this, let's look into this. And then when an overture is made, the administrator will be more receptive to giving the time.
Yeah, but when you go to tell the doctor, it's going to be covered by insurance, don't worry about it, it'll get paid.
Mhm.
And then the doctor's ready to do it and you're like, yeah, no, that's not covered. That was a lie. Yeah.
Yeah, we found that it's important to roll out things in a controlled fashion, covering all the bases first so that there's early success. and
Because
satisfaction.
early success is so important because when you're doing something new, if you have a setback because you did something wrong and you missed, everybody's going to remember that misstep. Your entire team's going to remember the misstep. So you don't want to have those missteps. You want to be careful and thoughtful in the integration and the process.
New things are disruptive and the team that supports you don't want to see disruptions. They want predictability day to day.
I agree. With that, I want to, sure. Yes.
I haven't found that.
I
I
case.
haven't seen that,
Pineapples
and I
have a
don't.
lot of connotation.
Yes,
I
there
heard
is,
that.
I don't believe
Lot
there
of
is
sugar.
literature to support that to my knowledge, but I don't know.
I
if
haven't
you
heard
know.
that.
Yes. So with that, the meeting will come
funny.
to an end, but the reception will start. The music will get lively. There are drinks and hors d'oeuvres. Please help yourselves and network and, enjoy yourselves. But I want to end by saying this. You honored us with your presence. I hope you got what you wanted out of this. Please fill out your questionnaires and give us feedback, what could have been done better. And also, enjoy the venue. This is one of the best spots in the city to have these kind of views. I want to give a special thanks to the lady on my far right, Patty, who, puts her heart and soul into this. Dr. Darbandi, as I said, I learn from you every time. Dr. Bowden is a mentor to me, and I appreciate him. And I appreciate each and every one of you guys being here. I also see great faces in the audience that have been supportive in our effort to bring more attention to this disease. And I agree with Patty wholeheartedly. This is a disease and we should call it that. So thank you and enjoy your night. And I hope you get to enjoy the music, the drinks and the hors d'oeuvres and get to know each other.
Congratulations. This is well done. You should be very proud. Oh.
different, that maybe wouldn't be in our